As a critical care paramedic, you're going to be seeing lots of labs as part of your, especially interfacility transfers, blood, urine, CSF, other bodily fluids of any kind. And really, the goal of us challenging you to understand what they mean is so that you can plan for the time in between point A and point B, essentially. You kind of know what's going on with the patient. If something goes bad, you kind of have a background knowledge of what's going on and plan for problems and interventions that will occur. This is one of the biggest advantages you have over a normal 911 call, ground ambulance transport. You're still going from point A to point B, but on a 911 call, you have really no hard data typically. Now, sometimes they will call 911 and say, my doctor's office called me and said I need to get to the ER right away because I had a lab drawn this morning and it was this, right? Great, now you've got that as well. But when you're doing IFT, you typically have a whole slate of labs to look at on your way to the receiving hospital. So really get to know that, plan for problems and interventions that will occur during the transport. It really supports an evidence-based approach to your patient care, and that's why we want you to anticipate, prepare, and deploy critical interventions when needed. Also helps establish trends for the receiving facility and for you. So we are about to go into some pretty mind-numbing stuff, but stay with me. I made it as interesting as I could. But it's really important, okay? We're going to talk about accuracy, precision, sensitivity, specificity, validity, PPV, NPV, and a bunch of other things. Why should you know that as a critical care clinician? I was just talking with Chief Stewart this morning a little bit, touching on this, in that we expect you to be able to synthesize new information. How do you do that? The latest and greatest journal article, right? The latest and greatest study. You're going to see, when you go to critical care conferences, vendors will be throwing stuff at you, say, look at this study, it says my product is the best. And you've got to be able to read that study critically and determine, is this crap? Or is this actually worth doing, okay? How do you know that? The first thing most people do is jump to the conclusion of a study. What were the conclusions? No, the first thing you should do is jump to the methods, okay? How did they get this information to draw a conclusion? Because if the method said, we asked 3 random bubbas on the street and they said this product was great, you can throw that out the window, right? I'm using an extreme here, but knowing things like accuracy, sensitivity, specificity, et cetera, will help. So you'll hear studies talk about how accurate or precise in their sensitivity and specificity something is, and you got to know what this means. Probably, I'm a very visual learner, and the best illustration of these mind-numbing statistical terms is pictures, and so the bullseye is great. Okay? So when we talk about accuracy and precision, they're not the same thing. Accuracy is a measure that some set of test values will actually hit the bullseye, that it'll be true, okay? It will be accurate. So on this photo, the bullseye represents truth. It represents that the values of the test will be as close, if not identical, to a true value. You following so far? Precise, precision is how likely is a value to be the same every time it's performed. It's precise, it's the same. You can almost say predictability, but I don't want to confuse things, but it is how well a test will get the same result every time, okay? So ideally, you want a test that is both accurate and precise, okay? Any shooters in the room? Yeah? Pistol, long gun, both? Cool. When you first start, you probably had targets that look like this, right? You're very precise because you're doing the same wrong thing every time, okay? But you're not accurate. Just for discussion, what is the problem with the shooter here? They're either jerking the trigger or they're usually anticipating the shot, right? So they're kind of doing this all the time, always at 7 o'clock. So you're very precise because you're doing the same mistake every time, but you're not accurate. Okay? Some tests are pretty accurate because look, it's pretty close to the truth, right? But it's not real precise. So it's kind of all over the place. That's a horrible test. It's neither accurate nor precise. So follow? Okay. Now then there's another kind of confusing concept that you have to know: validity and reliability. Validity, reliability, kind of related to accuracy and precision, but a little nuance. Validity, accuracy of a test or degree of achieving the intended result, so very close to accurate. Reliability is the consistency of a test or reproducibility of a result, kind of related to precision. How are they slightly different? Well, look at this pictures again. If you have this wonderful unicorn of a test, it is accurate, it is precise, it is also reliable, and it's valid. Okay, it's valid. The validity being achieving an intended result. Here, this test is not reliable, not super valid. This is low of both. It's low validity, low reliability, but both would be considered low accuracy and low precision. You follow? This is kind of varying a lesser degree of this. Okay, that it's reliable. In other words, it's very precise, but it's not valid because it's not very accurate. Okay, so related, slight nuance in differences. I would say that when you're looking at scientific studies, it talks more about accuracy than anything else. Now, here's where you really, really need to understand what we're about to say, because most of your studies will talk about, is this test sensitive or is it specific? You've heard of sensitivity and specificity? Okay, if you haven't, here it is. We're going to present this to you. So this is really where you have to understand. The measure of how accurately a test is able to correctly classify patients who have disease versus those who don't. This is what clinicians really want, right? Ideally, we want a test that's 100% in both. That would be perfect. You know, the perfect bullseye, accurate and reliable and precise and valid. Validity depends on two things that are typically inversely related: sensitivity and specificity. So what is sensitivity? Sensitivity is accurately detecting a person with disease. We're going to spend some time on this because students get tripped up on this all the time. Sensitivity is accurately detecting a person with disease. In other words, if you have this whiz-bang new test and it's very sensitive, what does that mean? It means that most people with the disease will test positive, okay? Accurately detecting a person with disease. That's the whole point of a test, isn't it? You want to find the people with disease. In other words, another way of saying the same thing is that a negative test, if it's highly sensitive, would probably rule out a disease. Okay? Another way of saying the same thing, that most people with disease will test positive. If a test has high sensitivity, the corollary is, well, a negative test then would rule out the disease, more likely. It won't rule it in necessarily, but it will rule it out. We're going to talk about that. Yes, question?
I guess it was kind of like that. I was just going to say, like, whenever I go on ESL and look at, like, troponin high sensitivity,
Yes.
it's basically saying that, like, high sensitivity even if they don't have troponin.
Yes, so when you see, so troponin I, TNI, is a specific biomarker of heart muscle that's specific to the heart. Before we had troponin, all we had was CKMB fraction and myoglobin. Both of them less sensitive for just the heart, because myoglobin can come from any muscle, right? So it really wasn't helpful at all to say someone's having a heart attack.
That would be specific, not sensitive, right? It would be non-specific, not mild.
Right.
Okay.
So if you had an elevation in myoglobin, they might be having a heart attack, but they also could have went jogging earlier. And so there's a little more myoglobin in the blood. It wasn't that helpful of telling you where the myoglobin came from. When troponin I was discovered and developed, troponin I only comes from the heart. So if that's elevated, it could only have come from the heart, which is why it basically got rid of myoglobin as a test for heart attacks and became the new standard. What she's asking is there's now an assay called high sensitivity troponin. That assay used to detect troponin is much more sensitive for detecting it in the blood. In this person, in that regard, we're defining disease as a level above a certain amount. And I'm going to give you a real-life example here in a minute, so this will start to come together, hopefully. Okay? If a test, however, has low sensitivity, many people with the disease will test negative because it's not real sensitive. In other words, another way of saying that is it's a false negative. You follow? All right. Now, we're going to talk about specificity. Specificity is a measure of detecting a person with no disease. You can also say it's correctly rejecting healthy patients. Does a test correctly reject healthy patients? Okay? So let's say that a test is developed and they say, you know what, it's very, very specific. It's got high specificity. What is the researcher telling you? They're telling you that this test they've invented will find that most people with no disease will in fact test negative, true negative. Okay, we rule it out. That means another way of saying the same thing, Russ, just like the one before, another way of saying the exact same thing is a positive test would more likely make you think they do have the disease and rule in the disease, okay, if it's positive. Because, why? Because it has high specificity. It's good at rejecting people who are in fact healthy. You follow? We're saying the exact same thing, people, just two different ways. Some people understand it better when we say true negative. Some people understand it better when we say a positive then probably is safe to say they have it. Okay? Now, if the researcher said, well, it's not really specific, but it's pretty sensitive. Okay, they'll say it's got low specificity. What the researcher is saying is that this newfangled test they invented, many people with no disease will test positive. In other words, false positive, right? It's not so good at rejecting healthy patients. You follow? All right. So now, of course, in a perfect world, we would have 100% sensitive and 100% specific tests. But that is not possible because the more sensitive you make a test, the less specific. The more specific you make a test, the less sensitive. The more body armor I put on my SWAT guys, the less effective they are because they can't move very well. Okay? When I first started on SWAT, we looked like we were wearing life preservers from the Coast Guard. Neck protectors, groin, we looked like, now we swung the other way. Okay? It looks like we're wearing a postage stamp with spaghetti straps. But man, we can move fast. Okay, so it's inversely, more armor, less fast, faster, less armor. You can't be both. Okay, you can't be wearing 80 pounds of armor and move fast, right? You can't have a test that's both. It's one or the other. It's a trade-off. Every time you increase one, you decrease the other. So what you have to learn is that we live in an imperfect world, which means that if you look at a bell curve of a test, and they show you this perhaps, this is representing the fact that the dotted line are people that have disease, which means that when you're looking for people with disease, anyone to the left of this line, because they're not diseased, will be a false negative. Conversely, on this side of the line, it's a false positive. So you're kind of looking for a sweet spot where the test is neither false negative or false positive, but it's believable. It's either. But then you have to know, is it very sensitive or very specific so that you can actually do something with that information. One of the tools that statisticians use to help answer this question is a concept called PPV and NPV, positive predictive value, negative predictive value. Follow along with me. If we're talking about positive predictive value, now the statistician is trying to help us out as clinicians to say, you know what, The probability that a patient returning a positive result is truly diseased is the positive predictive value. We're going to try to help you decipher the results of your test. The negative predictive value is the probability that a patient returning a negative result is actually healthy. So far, so good? It helps if you know what the mathematical formula for calculating that is, and it really is pretty simple. If you want to take PPV, you take the number of true positives as defined by some gold standard, and you compare it to your test. The number of samples that actually tested positive, you get your PPV. NPV is the opposite, the number of true negatives as measured by your gold standard of some kind over the number of samples that test negative. Let's take a look at that. Oh, okay. So a gold standard, that's a good question. So for those online, if you're listening, Russ asked, well, how do you then get the gold standard? Well, a gold standard is truly what we believe to be, at the time, our best way of measuring something. The example we're about to look at is AccuChecks, right? So an AccuCheck is a finger stick. We know that it's not like a serum blood test in the hospital where it's actually quantified in a machine. This is using an enzyme that kind of estimates what the serum glucose is, but it's pretty close, okay? So for us, in an AccuCheck, the gold standard is serum glucose, serum blood glucose, okay? Versus our test, which is a finger prick, and it's capillary blood glucose. You follow? Capillary blood glucose in an AccuCheck is an estimation of what the hospital machine will tell us is the serum glucose. To give you a practical example, if you get a finger stick blood glucose and it says HI is your result, what does that mean? High. It exceeds the testing capability of that little assay. You have to put it in an actual serum blood glucose machine at the hospital and they'll come back at 857, okay? But it exceeds the capability of that finger stick. So this is just kind of an estimation, but it's pretty good, all right? Follow? Okay. So using a real-world example, we look at AccuCheck. A study of 1,000 patients for disease is undertaken. How do you define disease? Disease for this study was defined at less than 70. A blood sugar less than 70 was considered low, okay? Hypoglycemic. So basically, you take 1,000 people, you run them all through a hospital-grade serum blood glucose machine, and it tells you what their actual serum blood glucose is. That's the gold standard. You take the same 1,000 people and finger stick them. Then you compare. How good was the AccuCheck at getting close to what the machine actually says? You follow? That's what we're looking at here, okay? They put these results in a foursquare where the diseased, out of 1,000 people, 200 did have a blood glucose less than 70, and 800 had a blood glucose more than 70. Diseased, not diseased. You follow? Now they tested everyone with the little AccuCheck sticks, and this is what they got. 160 people were detected as diseased, less than 70 by AccuCheck, okay? 40 people were falsely negative, because on the blood, they were less than 70, but on the AccuCheck, they were more than 70. Now, this might have been 71, it might have been 81, but the definition was 70. You follow? All right. So now, how do we calculate just sensitivity? Well, we take 160 people that were truly positive, divided by 200 that were really positive. What's 160 divided by 200? 0.8. So that means this test detected 80% of patients correctly as having hypoglycemia as defined by less than 70. Pretty simple, right? You follow? Well, what was the specificity? Take the same thing. We know that 800 people were not diseased. It was more than 70. And in fact, the AccuCheck found 720 truly more than 70. So 720 divided by 800 is 0.9 more. 90% of patients correctly identified as not having disease. Pretty dang specific, 90%. So now you're thinking, well, that's pretty good, man. I got 80% sensitivity and 90% specificity. This is the greatest thing since sliced bread. It's almost 100, woohoo! But wait, there's more. Calculate the PPV and the NPV. Let's do that. I gave you the formulas for calculating PPV and NPV, didn't I? PPV. Now, you take the number of true positives over the number of people that actually tested positive. How many actually tested positive? How many? Yeah, how many tested positive? 160 plus 80, because that was a true positive and a false positive, right? All right, so the number is 240. So now you take 160 divided by 240, now you have a PPV of 0.666. Ooh, 67%, let's just say 67%. That means the positive predictive value, 67% chance of being right. Not so good, huh, after all. But then you look at the negative predictive value. The number of true negatives, which is 720, divided by the number of tested negatives. So you got to add the false negatives in it too. So that's 760, right? Look at that. 94.7% chance of being truly negative, okay? So we already knew that it had 80% sensitivity and 90% specific, which on the face of it sounds pretty close to 100. I mean, that's pretty good, right? But now that you've actually plugged in the statistical analysis of PPV and NPV, now you know that the difference between sensitivity and specificity from a clinical standpoint leans towards specificity, right? We knew that there was 90% specificity versus 80% sensitivity. What does that mean to you as a clinician with a patient? It means that Accu-Check is better at ruling out low blood sugar than ruling it in, which is what we want, right? As a clinician, we want to make sure that they're not hypoglycemic as a reason for their dizziness, syncope, jitteriness, weakness, whatever. The negative predictive value is the probability that a patient returning a negative result is actually healthy. And this test specificity and negative predictive value is much higher than its sensitivity and positive predictive value, okay? Another way of saying the same thing, I like doing this, right, because some people understand it one way better than the other. Another way of saying the exact same thing is that if you get a finger stick blood sugar that says low, and it wants to tell you, oh, they're diseased, okay? But the patient feels fine. They look fine, they feel fine. What should you do? Give them an amp of D50? No, you should recheck, okay? Find another machine, or say, you know what? You don't look like you have a blood sugar of 25. So, and the patient says, well, I always know when I have low blood sugar, okay? And I don't feel that way. So maybe your weakness is from something else, okay? Maybe you should get a 12 lead instead and make sure it's not a silent MI, right? Let's wait till the hospital checks your blood sugar. Or ask the BC to give you their machine and check on their machine, or another ambulance check on their machine. Use the patient's home machine, just check and see what it says.
I was gonna say, do you mean like using like the same machine for another ambulance, or do you mean like using an upgraded machine like the hospital version in terms of?
No, I say on scene,
Yeah.
use a different machine.
Different one?
Yep.
We have two.
Not necessarily just our truck.
Do you have two in the truck? Use the second one on your truck. Open a different test strip. Maybe that one's got hot and it got degraded. Something. What I'm trying to say is that because of its low positive predictive value, if it says low and it doesn't match the clinical findings, you should know in the back of your mind, you know what, I'll just check another one because it's got more negative predictive value than positive. Make sense? Okay, so this is a real world example of how you use sensitivity, specificity, predictive value in your practice of medicine. How to be a discriminating consumer of technology. You know, you got to know your instruments, you got to know the test, you got to know how believable is it. And this is what helps you make clinical decisions. Okay? The bottom line is, for purposes of passing your exam, I need you to know sensitivity, specificity, predictive value. Okay? There are some statistical issues with applying certain tests clinically that's we haven't touched on is way beyond the scope of our talk today, but just to give you a little bit of a teaser, this graph really makes it evident that you have to understand this concept of predictive value, sensitivity, and specificity, because there are some tests that can not only be unhelpful, it can be harmful if you interpret it wrong, okay? Anything below this line in the red can actually be misleading. So you think, well, I've got a test that's it's 90% sensitive and it's 10% specific. That's a great test because now I can count on it if it's positive. Well, if it's 90% sensitive but 10% specific, it can actually give you misleading information. And again, it's way beyond our talk today, but again, the perfect test would be 100% sensitive and 100% specific, and you're up at the top of the green corner, right? But that doesn't exist. So what you're really looking for are tests within this fairly narrow line that are like 97% sensitive and 80-ish, 80-some percent specific, or vice versa. And now you're at least in the moderate evidence that it can help you. And unfortunately, most of our tests are in that zone, in the moderate evidence that it can help you, which is why we always say what? Treat the patient, not the test. Treat the patient, not the monitor. I routinely get lab results back. I once got a lab result where every single thing was so off. I'm like, is this patient dead? And I walk in to check the patient, and like, they're eating Cheetos, watching TV. How come it's taking so long for me to see a doctor? I'm like, okay, these labs are not right. So you have to put them all together, treating the patient clinically, okay? If it looks like death and they look like death and the labs look like death, okay, we'll make some presumptive actions on that part. But all right, enough of the nerdy stuff. All of this was in your notes. You can go at it at leisure, but synthesize those concepts, especially as it relates to statistics. Now, understanding lab values. This is where the real fun begins. Okay, we're going to talk about turning on your brain and talking about all the stuff in lab values, including things like CBC, BMP, electrolytes, and all that stuff. So let's look at the CBC. This is probably the quintessential lab that you will look at on interfacility transports. What is their complete blood count? First of all, the complete blood count will have a whole array of things. The main things you're looking at are the RBCs, platelets, plasma, WBCs. Understanding that the components of blood is about 55% the liquid portion, which is the plasma, about the rest of it, about 41-ish%, the RBCs or formed elements. You also have some platelets in there. And the other about 4%-ish of white blood cells, okay? So red blood cells will be carrying oxygen to the cells, platelets or thrombocytes for coagulations. The plasma is what contains your proteins, hormones, nutrients. White blood cells are your infection fighters, okay? So it would stand to reason that if you're picking up a patient who is ill, like a UTI, pneumonia, other kind of infection, you would expect a high white blood cell count. But you can't write in your trip sheet high white blood cell count because you're a critical care. You have to write the patient exhibits, not high white blood cell count. What's the medical term for that? No, for high white blood cell count. Smarty pants? No? Yes, thank you. Leukocytosis, okay? Remember, you're critical care. You can't be putting stuff like they be feeling sick. You got to put patient exhibits, significant degree of leukocytosis. I suspect sepsis due to Klebsiella or whatever. Well, then what's the opposite? Low white blood cell count. Leukopenia. Okay, they're leukopenic. Okay. All right. When you centrifuge it down, this is kind of what it looks like. Again, mostly plasma and then formed elements. And in between, you've got what's called the buffy coat, and that's where your WBCs and platelets kind of fractionate out. Okay. If someone is anemic and they have a lower hematocrit, you'd expect it to look a little more like that. If they have too many RBCs or formed elements, you'll expect the tube to look like that. But normally, this is what a normal fractionation kind of looks like, okay? So formed elements is about 45%. Fishbone diagrams. You will see these a lot when you pick up paperwork and the notes are scribbled out. I will say that you're actually seeing fewer of fishbone diagrams because handwritten notes are getting less and less common. But when I started, that's all we had. And so there were fishbone diagrams everywhere, okay? Now, for you, however, when you are taking notes, it may be helpful for you to actually adopt this shorthand so that you can write it down real quick. And this is basically the anatomy of a fishbone diagram. Looks like a fishbone because of especially the BMP. What is the old name for BMP? Yeah, basic metabolic profile, but it used to be called a Chem7. You still see some people call it that, especially old folks. They'll say, he got a Chem7 and it showed hyponatremia. A Chem7 is a BMP, what it's called today. It's because there are 7 things, 1, 2, 3, 4, 5, 6, 7 things. That's a Chem7, that's a BMP, basic metabolic profile. Ah, okay, because it adds calcium, I think? Yeah, all right. Yeah, so some of the iStat machines will be a Chem8, but anyway, that's what it is. We're gonna go through each of those throughout the day. Let's look at this first fishbone, the CBC fishbone. So on the left is your WBCs, in the middle is your H&H, and on the right is your platelets. And the relative normal values are there in the numbers. When we look at the CBC, the thing that I want to just kind of point out is that hematocrit is a fraction. So the hematocrit will change based on changes in what? Well, so it's important to know that the hematocrit won't change based on the red blood cells. So hematocrit is a fraction of the formed elements, which is the RBCs. So what will make that change? No? I'm saying physically, what will change the number? If it's a fraction, it's based on what? Well, so it could be, but I'm thinking more just, if we're looking at that picture of a tube that's fractionated out, plasma, in other words, hydration status, right? I would not expect the RBC count or hemoglobin to change based on being dehydrated or not. But the hematocrit will change because it's a fraction of, when you fractionate it out in a centrifuge, it is a measure of that fraction, which has nothing to do with physiology per se. It has to do with how much plasma is there, free fluid, okay? So why is this important? Because if I get a nursing home patient in the ER, or you get a nursing home patient that you're transferring, and their hemoglobin is normal, but their hematocrit is 60%, wow. They be dry, right? I mean, that nursing home hasn't watered this patient in a couple days, okay? So you would also expect one of their electrolytes to be changed, and we'll talk about that later as well, that is also affected by hydration status, okay? So don't let that test question fool you. You might see that, where it's like, what is hematocrit? And it'll say something like, the amount of red blood cells in the blood, and that is incorrect. You want to find the answer that says the fraction of red blood cells to plasma. That's what you're looking for, okay? So you'll hear people say, I need a CBC with a diff. Well, what does that mean? Differential, exactly. That's right. That means it has a differential. So when you have a high white blood cell count, the first thing I look at is the diff, the differential, because that gives me a clue as to why is that higher. Because if the neutrophils are really high, that suggests to me that the patient is fighting some kind of infection, okay? If the lymphocytes are really high, this doesn't always hold true, but I think maybe it's a viral infection as opposed to a bacterial infection, okay? If the eosinophils are through the roof, they're not really, they're coughing and sneezing and got a runny nose, and their white count's 12, whatever like that. But they don't have a fever, they don't really have any infectious signs, they don't have malaise, myalgias, any other viral syndrome. But they say, man, I ran out of my Claritin and my Flonase and my Singulair. Then I'm like, I would expect their eosinophils to be through the roof because that's what usually gets proliferated in immunoglobulin-mediated leukocytosis. Okay? They're not infected, they're fighting off seasonal allergies. What do you notice about those eosinophils that's different from all the other ones? They got all these red granules in it, right? They inflammatory mediators like histamines and stuff, that when that gets released, you're sneezing, you're snotting, you're lacrimating. All right, that's the bane of every seasonal rhinitis sufferer. So neutrophils, you think about bacterial infections, eosinophils, allergic reactions, parasites, worms, lymphocytes, viruses like mono and stuff like that, okay? The main component that we think about is red blood cells because it's the oxygen-carrying cells in our blood. They're biconcave. Why is that? Why are they shaped like biconcave discs instead of just a flat? It's easier to squish to get through a capillary. Remember that they go through single file through the alveolar capillaries. And if it was a round disc, it would be harder to squish, but it's shaped more like a beret, so it can fold easily and get through there, okay? The other thing is it creates a lot more surface area. So you can hold more oxygen because you can fit more hemoglobin on there as opposed to a flat surface, okay? You can fit a few more. When you multiply it by several million cells, billion cells, you can carry a lot more oxygen, okay? It's got no nucleus. It contains the plasma membranes, protein spectrin, and other proteins, major factor contributing to viscosity. What is viscosity? Thickness, okay? So if you have a hematocrit of 60%, your blood is much thicker and you're much more likely to thrombotic events versus if it were 30% and you were very anemic or at least overhydrated maybe and it was thinner, okay? Normal range, you can know these. Lifespan is roughly about 120 days. The relationship of erythrocytes to hemoglobin I thought was really nicely done today in your presentation about the oxygen hemoglobin dissociation curve. But suffice it to say that hemoglobin is that critical factor to account for whether a patient is hypoxemic versus just anemic. So one person asked me, how come you always get an EKG on GI bleeders and they're not having any chest pain? Well, because you can have MIs from a lack of oxygen, not just a clot. So if you exceed your, if your demand exceeds your supply, you can also get MIs. Right? You can also get ischemic tissue. So that's why hemoglobin is that critical factor. Also know that when you see SpO2, little p, that's the O2 saturation of the hemoglobin. P little a is measuring the partial pressure of oxygen saturation in the plasma. Okay. O2, CO2 molecules bind, and again, that was nicely elucidated this morning in your talk. So, states of hemoglobin. Carbaminohemoglobin is your normal states that carry oxygen and carbon dioxide. When you start having problems, especially in CO poisoning, it forms hemoglobin called carboxyhemoglobin. Now, if you do have a machine like a pulse ox that fits around your finger and measures that, then that's really helpful. You don't have to wait till you get to the hospital. What do you call that machine? It's not a pulse ox, it's a co-oximeter, C-O-oximeter, co-oximeter. So most of the fire departments have those red ones, which are the RAD 57s. They're the Masimo co-oximeters, and you can get a direct reading. Our current monitors, most of them also have co-oximetry on that. When I responded out to that big fire in South O'Fallon by the Highway 40, we set up our rehab, and we were checking the co-oximetry on all the firefighters when they came through rehab as well to make sure that they didn't have any high CO levels, okay? Methemoglobin, what is that? Methemoglobin is when hemoglobin, its ferrous iron, 2+, has been oxidized to ferric iron, Fe3+, which the bottom line is it can't carry oxygen or carbon dioxide. So basically, methemoglobin takes out the entire capability, oxygen or carbon dioxide carrying capacity. Something is wrong with the heme group. If you look at hemoglobin in electron microscopy, it has this very convoluted, like ribbon streamer structure, which is hard to conceptualize. So artist rendition looks more like that. A little bit more easy to conceptualize. And in the talk today, they also showed you the kind of taut and relaxed states, right? So same concept, hemoglobin being this globular protein. Normal values, just remember the average is about 15, and it's typically a 3-to-1 ratio. So if your hemoglobin is 15, you would expect the hematocrit to be 45, so 3-to-1. Okay? If the hemoglobin is normal, 15, and the hematocrit is 60, again, that makes you think that the fraction to plasma is much higher, which means they're dehydrated or hypovolemic typically. And the opposite is true. If it's 15 and the hematocrit is 30, then you might think that they're overhydrated. If both are off by a 3-to-1 ratio, then it's probably blood loss in the form of, if the hemoglobin is 10 and the hematocrit is 30, that's still a 3-to-1 ratio, right? But now you're thinking they've lost whole blood. And if the patient says, you know what, I'm really dizzy, and I kind of noticed the last couple of days my stool is like black and tarry. Now you know, okay, well, you've got a GI bleed and you're losing blood. Okay? Hemoglobin, carrying O2 from the lungs, CO2 from the tissues. Remember that O2 delivery is almost all from oxyhemoglobin. There is the vast majority of oxygen transport through hemoglobin. A couple percent may be dissolved in plasma, but it's mostly the oxyhemoglobin. So waste is then eliminated mostly through lung exhalation, again, as was nicely shown in the talk today. And that's how your body is going to get rid of that waste. When you look at this cycle, we talked about the Bohr effect, Haldane effect. So I love that precursor this morning. Okay? That's exactly that constant flow that's occurring through the tissues. And it's amazing how biochemistry helps our bodies function. The hemoglobin, what could anemia suggest? You can think about bleeding, we'd mentioned that, but also sickle cell disease. Why does sickle cell disease cause anemia? Is it a problem with production or a problem with destruction? It's the shape of the hemoglobin and the shape of the... It essentially creates sickle shapes in the red blood cells. You can imagine that instead of a nice foldable beret that goes through the capillaries, a red blood cell the shape of a sickle, you know what a sickle is, right? Maybe you don't. But a sickle is what the Grim Reaper holds. It's that big knife that's curved. Okay? Okay. Well, the Grim Reaper is holding this giant sickle, right? So that's a sickle. And that sickles used to be used for harvesting grain and stuff like that. It's a curved knife. You just swath it across and the grain falls, you pick it up, and there you go. So it gets stuck a lot in tissues, not just the lung, but sickle cell disease patients have this sickle-shaped red blood cells. They get microvascular ischemia all the time. So in a sickle cell crisis, their legs are hurting, their back is hurting, whatever, because they're ischemic. So that's terrible. Yeah. So another thing is cancer and chemotherapy drugs. Why would that cause anemia? Destruction. Okay. So sickle cell, problem with destruction. Chemotherapy drugs destroys the good cells as well as the bad. Iron deficiency, because iron is the essential element for hemoglobin to function properly, and if they don't have that, you can get anemic. And then polycythemia is when you have too many red blood cells, and that could be caused by being at high altitude for long periods of time. So people who are from Denver typically have higher hematocrit because they've adapted to the lower PaO2 from being mile high. It can be from dehydration, less plasma, burns, more fluid losses, which is why we have to replace fluid a lot in burns, chronic diseases, lung, heart, kidney, all those things can then cause polycythemia. Yeah.
So with dehydration, is it more hemoglobin or is the ratio of hemoglobin higher?
The ratio is higher in that you may have a hemoglobin of 15, but instead of 45 as your hematocrit, because you're so dry, The percentage related to plasma, because there's less, maybe 55% or 60. Because the hemoglobin doesn't change based on your hydration status, but hematocrit does, because hematocrit is a, what's the key word? Fraction. So look for that word in a quiz question. Fraction. It is the fraction in whole blood. So this is a very famous picture, and who here has seen this before? Only a couple, three of you? Really? All right. Well, it's almost in every textbook when they talk about methemoglobinemia. They are very hypoxic, which is why they're blue. Okay? But it's because they have this genetic inborn error that causes methemoglobinemia. This is the Fugate family from Kentucky, and there was a lot of, let's say, not too many branches on the tree, and so just one big branch, and so it got propagated in that community in Kentucky. Everyone was related to each other. So it could have been Arkansas too, you know, they're real close to each other. But it's a genetic mutation. And so it's incredibly famous pictures in every textbook that when you talk about methemoglobinemia. And it's been copied 1,000 times, and the artist is never credited. So I want to make sure the artist gets credited. It's Walt Spitzmiller was the artist. Anyway, the blue Fugate family from Kentucky was blue because they had methemoglobinemia. And any substance that oxidizes the heme group on hemoglobin will change hemoglobin into methemoglobin. So it doesn't have to be just a genetic error. It can be too much of certain medications, which we'll look at in a second. Anything that causes oxidization of the heme group will cause methemoglobin. So amyl nitrate, nitric oxide, nitromeds, benzolidocaine, food-grade nitrates, high doses can cause methemoglobinemia. This is why people in the ICU can't stay on like nipride drips forever, because it can induce methemoglobinemia. Okay? And because methemoglobin cannot carry either what? Or carbon dioxide, it causes this refractory hypoxemia, unresponsive to oxygen. You can put all the oxygen, you know, and blowing back their hair with oxygen, and it's not helping their O2 because it physically cannot carry it. You follow? So basically, their blood looks chocolate brown because it's deoxygenated, and they look blue. Okay? So the treatment is discontinuing whatever offending substance it is, and if it is from that, then you can also give methylene blue, which deoxidizes and helps to reverse that. Okay?
Dr. Tan, I
Yeah.
had a patient who actually attempted suicide by taking sodium nitrate at home.
Really?
Food-grade nitrate. When I got to him, he was gray like I've never seen a gray person before. Super gray. We did a high flow too. His initial sats were like 30, 40%.
And he was still alive?
We called ahead to the ER. It was in St. Charles. I called St. Joseph's and I said, I need methylene blue standing by. And to their credit, when we got there, they had methylene blue standing by. They did immediate infusion, saved his life.
Really?
He went to ICU and survived.
That's amazing. Where do you get food-grade nitrate? I didn't even know you could buy that.
Amazon for meat preservation.
Oh, sure.
And so he got a bunch of it on the internet.
Meat preservation, yeah.
So that family, they're chronic in that, right? They live
Yeah.
with it. How they live like that?
Well, because they are born with it, they kind of adapt, and they live blue, essentially.
Are they asymptomatic though? Like
Well, I don't know that they're asymptomatic, other than they just kind of adapt to it, and they can live life. I don't think they're running marathons or anything, but yeah.
And they're not real smart either, right? I mean, they're.
Well, for different, maybe for different reasons. They have issues. They have issues, yeah.
So if they were extremely hypoxic, a blood transfusion would work for them? They would oxidize that?
Yeah, well, no, the blood transfusion would work per se, but how long does blood live? Like, how long does it last?
120 days.
How about 120 days-ish? So it would not be possible to get transfusions every 4 months. You know, I mean, that's just for the rest of their life. That would not be.
I was thinking acutely, they had like a respiratory disease. Like,
Yeah, maybe.
they could get a
Yep.
transfusion.
Yep. I have not. Any methemoglobin patient I've ever had has been a tox condition, not a genetic one. So I actually don't know the answer to that. But I'll try to find out.
Genetic in the area. I was working for a
particular individual was frequent at one of the hospitals, and they just that's where they live. Like the blue color is like not even a joke. Like they look Smurfish.
Yeah.
And that's just where that person lived. So.
Yep. It's pretty striking. It's not subtle. They look like a Smurf. Exactly. It's not subtle. Yeah.
So we had this lady, when I worked out at Warren County, that was related to a STARS patient, that she used some type of makeup in the 70s that turned her face blue, and only her face. Do you know what that was called?
I do not. But I don't think that would be related to methemoglobinemia. It was just probably just a toxic reaction to the skin.
Yeah, she looked like a Smurf.
Yeah, yeah. Yeah, it sure does. Yeah, methemoglobinemia is definitely a whole systemic thing. Your whole body would be blue, not just your face.
So if people that get methemoglobinemia from incest, because they're born with it, are they more tolerable?
Yes, they tolerate it
Yeah.
more because they're born with it. Yeah, but I'm sure it limits the amount of exertional activity they can do, but
Sure.
they tolerate it.
Yeah.
Probably not enough because it's popping up.
All right, hematocrit. When we look at how does the relationship between hematocrit and hemoglobin change? Remember, we said it's normally a 3-to-1 ratio, and this table is also in your notes. But you should notice this because you might get like a scenario where you have to interpret what's going on based on the CBC. And here's an example. We said that I already gave you this one, right? The hemoglobin's normal, it's unchanged. But the hematocrit is down, it's low, it's like 30%. Well, they could be either overhydrated, like volume overload, or why would pregnancy show this imbalance in the 3-to-1 ratio? Yes, because in pregnancy, your blood volume normally increases, and so it's going to dilute your percentage, your fraction, right? And so that fraction will be reduced. It'll be, instead of 45%, it'll be 40%, 38%. Okay? What if it's normal, but it's high? We talked about the fraction being 60% or something like that. They could be dehydrated, they could be polycythemic. Polycythemia meaning too many RBCs. Polycythemia is a condition where the bone marrow produces way too many red blood cells. And you know what the treatment for that is? Bloodletting. It's actually bloodletting, yeah. If both are high, both the hemoglobin and the hematocrit are high, then you would think that maybe that is from low oxygen states. Maybe they were born in a mountaintop. They live in Denver. They've got pulmonary fibrosis. They have COPD. And as a compensatory mechanism, the body's trying to make more oxygen carrying capacity. But if they're both low, hemoglobin's down, hematocrit is down, now you're thinking they're losing all their blood, including the formed elements and the liquid elements, so their guy on GI bleed someplace. Okay? So,
immediate blood loss not necessarily reflects.
yes. So what he's asking is, another way of asking his same question is, if you have a patient who was shot in the gut and their heart rate is 140 and their blood pressure is 80 and their stomach is getting more distended, but you whip out your handy dandy iStat machine, oh, his H&H it's 15 and 45, he don't need no blood. It's because the H&H does not always reflect acute losses. It hasn't reached equilibrium yet in the body, right? Now, by the next day in the trauma ICU, the H&H will be 7 and 21, okay, if he hadn't gotten massive transfusion protocol. But acutely, it's going to be 15 and 45.
That is why we don't give any fluid resuscitation until their blood pressure is unstable, correct?
Well, not really. The reason why we don't dump 2 liters of crystalloid into a trauma patient who is awake and talking is because we don't want to dilute the proteins that we talked about are in the plasma. And we don't want to disrupt any clots that are forming and make them bleed faster. That's why.
Yeah.
That's the main reason why. So, WBCs. We talked about RBCs, let's talk about WCs, leukocytes. There are 5 types. We kind of alluded to them earlier, but typically neutrophils are what fights infections. Then you also have basophils, eosinophils, et cetera. Leukocytes are about 4 to 12 typically is a normal range, 4,000 to 12,000. So that's something else to note. When you see shorthand on the fishbone diagram, WC is 4.5. It doesn't mean 4.5, it means 4,500 leukocytes per microliter. Okay, that's just shorthand. They fight infections, they do have a nucleus, leukocytosis, leukopenia for high and low. Platelets are these teeny tiny fragments that help in coagulation. 150,000 to 400,000 is your norms. Okay. We don't start worrying about transfusing platelets until it's less than 50 or 50,000. There are some oncology patients on chemo where the oncologist won't even think about transfusing platelets unless they're either actively bleeding or it's less than 25. So it kind of depends on the institution, it depends on the physician, but when I get a little bit nervous in the ER is when it hits 50 or lower. And especially if they come in with a bleeding problem, like a cancer patient with a nosebleed and their platelets come back at 40, I'll give them a 6-pack of platelets. Okay? So platelet plugs are usually temporary. It's just a quick fix to help stem the bleeding until the fibrin and more substantial clotting can take place. Yes?
Sorry, what is the
Microliter, also per microliter. Yeah. Decreased platelets, the medical term for that is, because you can't say decreased platelets on your trip sheet. Thrombocytopenia, very good. Increased thrombocytosis. Okay. So remember these common lab values. Common lab values, the normals for RBCs is 5. What's the common one for hemoglobin? We said this 4 or 5 times already. 15, and then 45 because of that 3-to-1 ratio, right? RBC transfusion, usually if it's less than 7 or 8, we are wanting to give a transfusion, so just as a reminder. This is going to help you put together your clinical picture of the patient when you're looking at their CBC. Make sense? So hopefully that gives you a better understanding. We are now going to move away from the CBC and move into our BMP or Chem7 or basic metabolic profile, which has a bunch of your electrolytes. Before we jump into that though, a very good question came up during the break, which was, does the diff also have bands? That's something that we didn't quite touch on. I don't know that that would be on your exam, but because you're all scholars and someone asked, let me answer that real quick. So what else is on a differential? Well, besides the diff, which is the percentage of neutrophils, basophils, eosinophils, all that stuff, at the bottom of that is typically a band count or bandemia. What is that? Those are the immature cells in the bloodstream. In other words, cells that are undifferentiated to yet become neutrophils, basophils, leukocytes. They're still in kindergarten trying to figure out what they're going to do. Okay, so they're still, if you think about leukocytes as soldiers, the bands are the ones in boot camp. The neutrophils are well, how do I say that without offending one branch or the other? You know, are they the Marines maybe? No, I don't know. But, you know, yeah, neutrophils are the infantry. They're the soldiers, right? They're the ones that are fighting the bacterial infections. They can actually, you know, win this war if they have enough time. And then the lymphocytes, all that stuff, they're all soldiers, but they're all different branches of the military, right? The bands are still in boot camp. So what does that mean to you clinically? It means this, that if you see a leukocytosis and the whites counts 15, and oh, they've got neutrophilia too. They're like 55% neutrophils, or 60%. They're probably, we gotta look for a bacterial infection. But then the bands are normal. It suggests, not always, but it suggests that the regular military people can handle this problem, and that with enough support, they should be able to defeat this enemy, whatever that enemy is, okay? But if you see a white count of like 25,000 and an 80% neutrophilia and a bandemia, meaning the band count is also high, that means you're probably losing this war. That means the boot camp has just kicked out the recruits. Are you breathing? Yes. Can you pull the trigger? Yes. Go fight, okay? They're not ready, but they can fire a weapon. Okay, so you have a bandemia on top of leukocytosis, things are pretty bad. Okay, if you have leukopenia and bandemia, that's really bad, right? That means all your regular military is wiped out. Your white count is 3, and you've got a bandemia. If you live that long, because a lot of times you don't live to get to that, okay? But if you live that long, things aren't looking good. This is why in sepsis criteria, the mortality is much higher if they meet sepsis criteria from leukopenia as opposed to leukocytosis. Okay? If you're going to be septic, have leukocytosis, okay? But if you're septic and leukopenic, your mortality rate is really getting high. Okay. That answer your question, Russ? Okay, great. Bandemia. Okay, now we move into the fascinating world of electrolytes and chemistry. So now we're going to talk about the stuff on the BMP, things like sodium, potassium, chloride, bicarb, BUN, creatinine, glucose. Most of our time will be spent on the first two, sodium and potassium. Why? Because they're the main, exactly. So those are the big players on the chem profile. Not that the other ones aren't as important, but man, sodium and potassium really determine someone's health status. So we're going to spend most of our time on that. Let's look at first the basics. What are ions? Ions are atoms that have an uneven number of charges. It can be either net positive or net negative. I have a really stupid way of remembering the difference between cations and anions. I'll share it with you, don't laugh at me. But if it helps you remember, then great. I remember cations are net positive because cat, T, positive. You know, cat. Anions, like onions or onions, make you cry. It's very negative. You don't want to cry. So, stupid, I know. If you have another way of remembering, use your way. But I remember cations are positive, anions are negative. And that's how I remember. Cations have a net positive charge, anions have a net negative charge. And so calcium, for example, when you see calcium written, it's Ca2+. What does the 2+ mean? Does it mean it's twice as good as other? No. It means it has a net positive charge because it lost 2 electrons. So you lose 2 electrons, you get a net positive charge. Chloride, however, is written as a Cl with 1 minus sign next to it. That's because chloride gained an electron. Okay? So when it gains an electron, now it becomes an anion because it has a net negative charge. You follow so far? All right, cool. So you also have to know the attraction between elements. Now there are several, like ionic bonds, covalent bonds, metallic bonds, but this is not a chemistry class, so we're not going to go over all those, but you do need to know what the first one is. You need to know what an ionic bond is because when one metal atom and one non-metal atom join up, because one atom donates electrons to another atom, that forms an ionic bond. And perhaps the most quintessential example of that is good old-fashioned NaCl, sodium chloride, or salt, right? So sodium atom and chlorine atom marry up together. You got a cation and an anion. They share a bond, an ionic bond, and produce sodium chloride. What then is an electrolyte? Okay, we defined what ions are. We defined what an ionic bond, therefore, is to make like salt. What is an electrolyte? An electrolyte is a substance that dissociates in water into ions. So if you have a substance that dissociates in water and forms ions, positive or negative charges, that is one of the criteria for an electrolyte. As a result, it conducts electricity because of this dissociation into ions. They're essential minerals vital to key bodily functions. So for example, if you put sugar in water, does it dissolve? Is it soluble? Well, yeah, you can make sugar water. Okay? It dissolves in water and soluble, but sugar does not dissociate into ions, positive and negative charges, and it doesn't conduct electricity per se. But when you put salt in water, salt water, it does dissociate into ions and it conducts electricity. So you should know what the extracellular and intracellular ions are. That's a super easy quiz question, right? All of the following are intracellular except, or vice versa, right? The easy Extracellular ions are on the left in red. The intracellular ions, that's what the green circle is supposed to be, a membrane. Poor man's cell. Intracellular are K, mag, PO4 phosphate, and proteins. Those are your intracellular items. Let's look at the CMP. Actually, this is the BMP, because the CMP has other things. So sodium, potassium, chloride, CO2, BUN, creatinine, glucose. Let's look at sodium first. Sodium, this is how they're going to be laid out on a fishbone diagram if you happen to see it. Or if you're writing your own shorthand, this is how you can write it out. This is also in your notes so you can memorize it. Normal is about 135 to 145. The units of measure are milliequivalents per liter. Milliequivalents per liter. Of course, one of the most abundant cations in the body binds easily to chloride. That ionic bond is very easy to make sodium chloride. Sodium attracts water and pushes it around the body very easily in a process of osmosis, and water follows sodium. Water follows sodium. Sodium levels are a great marker for fluid status in the patient. So for example, when you look at total body water, most of our total body water actually is in the cells, about 2/3 of it. The rest of it is extracellular, but most of it's in the cells. The ones that are outside the cell, this is where you have interstitial fluid, which is kind of that third space. It's neither in the cells, neither in the vessels, but it's in between. And then the other 8% is your plasma, that liquid portion of the blood we talked about earlier, right? So when we talk about movement of water in the body, water can move freely within our body spaces. And water itself is not necessarily restricted by things like pumps. It doesn't have to have a pump. It doesn't have to have a receptor. It's just water. Osmosis, therefore, is this process of net diffusion. We had a very nice discussion on diffusion this morning, caused by a concentration gradient. Okay, so diffusion of water will go from an area of low sodium concentration to an area of high concentration. That's osmotic pressure. So water follows sodium because water wants to equalize sodium concentrations within the body spaces. Okay? So when you look at cell plasma membranes, some are semi-permeable, selective, some require channels, but sodium, through a semi-permeable membrane, water will follow sodium. And what will eventually happen? Sodium is a very important regulatory electrolyte in our body's fluid balance requirements, which is why, in addition to hematocrit as a marker for hydration status, you can also look at sodium as a marker of hydration status. You're going to see a very sad case shortly where that was disrupted and preventable. Let's look at the sodium body-water relationship real quick. Tone. If you have intracellular fluid, your body cells, for example, and your sodium is 140, which is about normal, and your serum is now 155, that's what you get back on your BMP. What can you say about tonicity, the number of solutes present? Is it higher or lower? Higher, because you have more salt, right? Isotonic is when sodium is at normal levels, because we said normal sodium level is 135 to 145. 140 is right kind of in the middle. But if you have more salt, then it's a hypertonic solution. How about the other way? We already know that that's hypertonic, and that's going to be hypotonic because it's less than your 135. Okay? So the measure of concentration of a solute is its osmolality or osmolarity, whereas osmolality is the calculated amount in a kilogram, whereas osmolarity is the amount in 1 liter. So one is by weight, one is by volume. But they're essentially measures of two similar things, just a different way of calculating it. Water tends to move in the direction of the compartment that has more solutes. Remember we said water follows sodium because water is trying to equilibrate and dilute it out to reach equilibrium. Nature hates a vacuum in one place or the other, so this is just its way of equilibrating that. So a higher osmolarity, you can think of it as similar to osmotic pressure or the process of osmosis. In other words, again, The take-home message is water follows sodium. So water will move towards higher osmolarity, leaving the area of lower osmolarity to equilibrate. So pretty straightforward. One of the reasons why this is important is particularly hypernatremia and hyponatremia as it relates to the brain. The organ most affected by sodium disturbances, either hyper or hypo, is the brain. So hypernatremia in the blood, what does that do to plasma osmolarity if there's too much sodium in the blood? It goes higher, right? So now you have more concentration. Water is drawn out of the body cells because water follows sodium. So what does that cause to the cells? Shrinks the cells because it's sucking all the water out. And hypernatremia, therefore, is anything above the normal value, which was 135 to 145. So if it's 155, it's hypernatremic. So we kind of talked about this at-risk populations, nursing home patients, psych patients, victims of dementia, infants. What do they all have in common? Not enough, they don't control their own water intake. They're dependent on a caregiver or someone else to help them regulate their water intake. Okay? So what happens when you get super hypernatremic? Well, you can get restless, agitated. The whole reason that you have neurologic changes in nature is because it affects the brain more than any other organ. Water follows sodium. Okay. So one of the diagnostic algorithms for hypernatremia, number one, is assessing their volume status. Because you can have a high sodium content, but that alone doesn't tell you anything if you don't look at the overall volume status. Are they euvolemic, hypovolemic, or hypervolemic? Then plug in your sodium level, 155, 160, whatever you will. So if you look at that patient and they are hypovolemic, total body water is down, and you think that their total body sodium is down as well, but they're hypernatremic, then what you do is look at their urine sodium. You can measure that as well. Greater than 20, less than 20. If it's less than 20, you think about extra renal losses like burns, diarrhea, fistulas, you're losing lots of fluid, decreased water intake as well. Their overall total body volume is less, and their sodium is therefore going to be concentrated, so they're hypernatremic. If they're euvolemic, total body water might be down a little bit, but their overall sodium hasn't changed. Their urine sodium doesn't work as well, but you can look at renal and extrarenal losses still as a potential cause for the hypernatremia. But if their total body water and sodium is up as well, so you've got sodium gains, usually endocrine problems like hyperaldosteronism and Cushing's, or they have hypertonic dialysate in their bloodstream. For whatever reason, they've gotten a bunch of hypertonic sodium bicarb. They take salt tablets. Some people will, in a misguided attempt to keep their electrolytes balanced when they exercise, and they're exercising for 30 minutes and they're dumping salt. That can also do something to their salt. Mannitol? Well, since it's an osmotic diuretic, so it may cause overall volume to be down. So I would think that if it did, it would be in the hypovolemic stage from osmotic diuretics, because that's what mannitol is. You know, mannitol, Lasix being your loop diuretic, mannitol being your osmotic diuretic. It's going to be I would put that in the category of renal losses. So that would probably be in that category. Okay.
I have 3% no saline.
Yes, that would be like some exogenous administration of saline.
All right, Tan, can you go to the back 2 slides? Remember these nursing home patients, guys. How many times have you responded to these patients for agitation? And what's the nurse saying? It's a psych issue, right? You gotta keep this as differential. It may not be psych, it may be metabolic. Hypernatremia is a big cause of this. Could be a cause of what's going on, so just keep that in mind.
Yeah, that's a very good point. Premature diagnostic closure is something that a critical care clinician cannot fall victim to. So always keep your differential broad and consider a metabolic cause, especially if the nursing home is like, well, this is just psych. If they have labs, take a look at it. That's the whole point of you learning this module. And if they're so, well, Did anyone address the sodium of 160? Well, we didn't even look at that. Well, okay, let's go to the hospital.
This might be a stupid question, but before you had the examples of like if the sodium in the cell is like 160, we're never going to know that. Like, so if the sodium
No.
in the blood level is like 150 and in the cell is like 170, we're not going to know that we're actually hypotonic in the
Right,
serum,
right. I think that's more for you just understand the movement
Okay, so
that
it's
water,
actually-
no,
okay.
water follows sodium. What you will know though is their serum sodium level that you get. So now you can think, okay, are they overall hypertonic, hypotonic, or isotonic?
Okay.
What will that do to cells? So if they're hypotonic,
Yeah.
then you think that there's more salt in the cells, you can guess that. And what will happen to the cells then? Will it shrink, stay the same, or expand?
It'll shrink.
It'll, well,
If we're hypotonic in the serum,
in the serum,
the water.
water follows sodium.
Yeah,
So there's probably going to be,
expand.
so the cell will bloat, and you're at risk for bloating the cell and maybe rupturing that cell because of hypotonicity.
So we should assume that the cell is going to be within normal limits as serum is off.
We should, yes, we should assume that water follows sodium. Probably can't emphasize that enough to you this morning, because that's what we're really trying to drive home is understand that water follows sodium to try to equilibrate it. So to answer your question, you're right, we won't know what's in the cell, but we do know what's in the serum. And that's all we can do. So also, no, I don't think I said this, but you wouldn't necessarily expect EKG changes. So if you are given a scenario and the sodium is off, but in the stem of the question or on a related EKG, there's EKG changes that you're supposed to relate to the electrolyte disturbance, it probably isn't the sodium, right? Because the sodium doesn't cause that. What if we're talking about potassium, though, which we will next? Then yes, you have EKG changes with potassium, but not with sodium. The treatment is directed at correcting the water imbalance, whatever that is. If they're euvolemic, then maybe not so much, but if they're hypo or hypervolemic, that's what you kind of want to treat. But what you want to do either way, if they're hypernatremic, is the blood is too salty, so to speak, so you can provide some fluids. Hypernatremia is not such an emergency that you have to correct it quickly, which is opposite of what we're going to talk about next, hyponatremia. So judicious use of fluids, usually just giving them some free fluid is all they need to then re-equilibrate relatively quickly, but you don't have to start dumping D5W in them to try to dilute them out. You're going to cause way too many problems, okay? Because if you overly correct it, what are you going to do? You're going to cause cerebral edema and death, because water follows sodium, like we said. So you're going to then make it so that you overcorrect too fast, and you never have to do that in the first place. Hyponatremia, though, there are some instances where you do need to correct that, like within minutes or they die, and we're going to look at hyponatremia next. From a clinical standpoint, hyponatremia is much more concerning than hypernatremia. Hypernatremia is a very fun academic exercise. Well, the euvolemic, hypovolemic, who cares? Just give them some water, and they'll be fine. Okay, but hyponatremia is when blood decreases, the plasma osmolarity is decreased because of hyponatremia. What does this do? This draws water into the body cells from the blood, causing swelling and edema in those cells, because your blood is hypotonic relative, right? So that means there's more salt in the cells. Water follows sodium. It's going to cause swelling and edema in those cells. So anything less than 135 is considered hyponatremia. Once you start getting below 125, though, that's pretty significant. Anything in the 1-teens, sometimes they go to the ICU. So I will also say that it kind of depends on the rate at which hyponatremia develops. That depends how sick they are. If the hyponatremia develops over days to weeks, sometimes they can tolerate that more than if it occurs over hours. The same 125 over hours versus 125 over days is very different clinically. Okay? So causes of hyponatremia. You can have kidney problems where you suddenly go into renal failure and you're not peeing anymore, And so you're retaining all your fluid and you start diluting yourself out. But exogenous fluid is also a very bad one because the kidney problem may occur over a longer time, but water intoxication is such a thing. Has anyone heard of water intoxication before? Yeah, so it can be asymptomatic if it's very gradual, but man, a rapid decline can be fatal. You start with a headache, like they get a headache, then they get restless, then they get a little lethargic, and then they get hypotensive, then they get altered, then they seize, and they go into a coma, and then they die. And that can occur over a couple hours, depending on how rapid that hyponatremia occurs. Probably one of the saddest cases, and I hate talking about it, but it really drives the point home, is the case of Jennifer Strange. If you've never heard about it, this is a totally normal mom, a mother of 3 beautiful kids, just trying to do something nice for her kids. It was around Christmas time. She didn't have enough money to buy them a Wii game controller. So the radio station had a contest, a stupid contest. Hold your Wii for a Wii. Whoever could drink the most water without urinating won a Wii. So she said, well, that's easy. I can drink a bunch of water and hold my pee. I'm good at holding my pee. This is a picture of her in the lobby of the radio station. She began complaining of a headache, I want to say about 90 minutes in. The radio DJs were laughing at her, say, hey man, you're doing good. Hey, they took a picture of her belly, like her bladder distended, and said, hey, you look like you're pregnant. And she had acute water intoxication. She complained of a headache. And then she seized, she went into coma, and she died. So needless to say, the radio station lost, I think, their license, but they did lose a multi-million-dollar jury verdict. So what happens with hyponatremia? Water in the plasma will pass from the hypotonic serum into the hypertonic brain cells, causing cerebral edema, and that's why you get the headache, the nausea, the malaise. So, you know, moderate, once you get to the 120s, 125, we already said that 125 is considered significant, pretty critical. Anything less than 120, you're at risk of going into seizures, coma, and death. So if the hyponatremia was over 48 hours, you think this happened over a couple of days, then no, you don't necessarily want to correct them too fast. The condition that you'll often read about is CPM, central pontine myelinolysis. There are some law firms that have built their whole practice around winning arguments over CPM. CPM occurs when you correct hyponatremia too fast, you get cerebral edema and brain damage, and you get cerebral demyelination, essentially. The myelin sheath in the brain begins to melt, for lack of a better term. It can cause severe and permanent neurologic damage, but I will tell you this, CPM is very rare in patients who have hyponatremia that is acute, less than 48 hours, certainly Jennifer Strange over a few hours, or if the plasma sodium is more than 120. Remember we said that it's the degree of hyponatremia, so if you start with a normal sodium of 140, and you're on the stupid radio station program and you drop it to 125, well, it may not be 115, but you dropped it to 125 in a couple hours. Well, these are actually patients that will, not may, but will get better with rapid correction. Hypertonic saline is the key. So that's 3% sodium chloride, acute hyponatremia. So if you're the responders to this radio station, and this lady has all the signs and symptoms, they've been doing the stupid contest, and this person has all the signs and symptoms of cerebral edema, that's when hypertonic saline might actually be helpful. The way they figured the dosing was through this study by Ayus and Moritz, who has quite a bit of experience in using hypertonic saline, but they did IV pushes of 3%, maybe 100 to 150 cc's each over about 10 minutes. And basically they titrate to effect until the patient's mental status starts to get better or seizures stop or something like that. Again, acute elevation, certainly if it's more than 120, this is perfectly safe to do. An alternative, if they have hyponatremic seizures for whatever reason, I would definitely be giving the hypertonic saline, but also if you're not exactly sure what the sodium status is, then sure, you can do benzos like you would for any seizure, but once you have any suspicion that they're hyponatremic, you can give hypertonic saline. Remember we said sodium bicarb is also very hypertonic, is very high in salt. If you don't have 3% sodium chloride, you can also give sodium bicarb. Salt is the main therapy. That's the take-home message. Then secondary treatments include your endocrine pathway of helping to re-establish homeostasis. So desmopressin or DDAVP, that's a synthetic type of antidiuretic hormone. It, of course, like ADH, it helps your body retain water by reducing urine output. That's 1 to 2 mics IV every 8 hours or so. That's DDAVP again, a synthetic ADH. It's less of a vasopressor than vasopressin itself, has a longer duration and more potent, which is why it is preferred. So number one function, to retain water when needed. Now ADH, which is vasopressin, is also made in the hypothalamus, also retains water. Your body will release ADH as a defense mechanism. If it detects the body experiencing low blood volume or high sodium concentrations in the blood, then it will try to correct that through the endocrine system and release ADH. Now, remember that diabetes insipidus, what is that? That's a problem where you're what? It's impaired antidiuretic hormones. So they're losing tons of, that's constant urination, they're losing way too much water. Renal dysfunction, failure, that's the opposite. So diuretic-induced hyponatremia is almost due to thiazide classes, less so of loop diuretics. So sodium follows water. Remember that water tries to equilibrate, and when it comes to sodium, the worst abnormality is going to be hyponatremia, not hypernatremia. Both are bad, but hypo is going to kill you, especially if it happens acutely. We are on slide 81 of 248. So I am, and the other thing is I hate when instructors just stand there and read the slide. I try not to do that. There are some slides that are fairly heavy word-wise. What I'm going to do, if it's okay with you, is kind of point out highlights of it, but I'm not going to read it to you like we're in 3rd grade. It's very readable, and on your notes you can read it yourself, as well as supplement with read the textbook. These notes supplement the textbook, and then if you have a specific question, please don't hesitate to ask. That fair enough? I really do want to get through as much as possible today. All right, so once again, the title of the slide is incorrect. It is not CMP, it is BMP, Basic Metabolic Profile, which is the Chem 7. CMP is a bunch of other things, but just so you know, a CMP includes this, but it adds a bunch of other things. But what we're looking at today is the BMP or Chem 7 Basic Metabolic Profile. So we talked about sodium. The next big one that we're going to spend time on electrolyte-wise is potassium, because potassium is key to our cellular processes, but abnormalities in potassium really can kill us. So you really got to know K very, very well. Potassium is one of the primary cations, cat with a T, so it's a net positive charge. It is the key intracellular cation in the cells, and it is the key electrolyte responsible for depolarization, metabolism, production of proteins. Inside the cells, interestingly enough, K is 140 to 150. But what should it be outside the cells? 3, just over 3 to about 4.9, or 3 to 5 is close enough. You know, one of the memory aids that Chad Metz was telling me out there in the hall was, you know, you go to a store, you buy bananas, you don't buy 50 bananas, you buy 3 to 5 bananas. So the normal potassium, that's good, right? I mean, I like that. So it's about 3 to 5-ish for a normal potassium level. So anything more than 5 then is considered hyperkalemia, and if you get more than 6.5, you start to get critical and worry about potential death, okay? Again, like sodium, it is not necessarily the degree of hyperkalemia or K, yeah, hyper K, but it's how rapidly you get there. Yes, a K of 10, no matter how slow you get there, is really, really bad. But if you get to a normal K to 10 quickly, well, you probably wouldn't live to get that high, actually. So the rate of elevation is key. Where can you get hyperkalemia from? So salt substitute is a big one. There used to be a rash of these when no salt first came out. Do you remember that? The whole low salt diet craze in the late 80s, early 90s, and they're like, hey, cut your salt intake. We got this dietary supplement called no salt. It's no salt at all, but it makes your food taste salty. And basically it's potassium iodide. And so people thought they were being healthy by sprinkling no salt over every dang thing. I'm not using salt, and then they got hyperkalemic. So excessive K, crush injuries, tissue necrosis, rhabdo. Our med specs on the USAR team are intimately aware of crush syndrome and hyperkalemia, how to diagnose it, how to treat and manage it. Succinylcholine administration. It does because it is, what kind of depolar, oh, I just gave it away. Thank you. It is the only depolarizing neuromuscular blocker, right, in our formulary. Everything else is non-depolarizing, but because it's a depolarizer, it does cause a transient rise in K. Usually not a big deal. There is a disorder where if the patient has a history of this and you need to do RSI, you probably don't want to do a depolarizer, right? So you remember what that muscular disorder is? It's a motor end plate disorder, myasthenia gravis. So if they have a history of myasthenia gravis, theoretically you're supposed to use a non-depolarizer instead of a depolarizer. So the other thing is metabolic acidosis. If you have, say, DKA, or frankly anything that raises the acidity, i.e. lowers the pH in your blood, your cells are going to try to buffer that a little bit by helping to get hydrogen ions out of the cell, out of your blood into the cell. But what that does is it drives more K out. Low enough acid levels also causes hemolysis and destruction of cells, so then it's just releasing all its K into the cells that way. So it's kind of a double whammy. So that's why you get hyperkalemic. Oh, and here it is, of course. I should have just clicked on the next slide. So there it is. So in its attempt to buffer, it will increase K, cause hyperkalemia. So the effects of hyperkalemia include things like weakness, general weakness, muscle paralysis at really high levels, cardiac conduction abnormalities. That is the primary thing that we worry about, is cardiac dysrhythmias. So point of care testing with iStats are really pretty specific for hyperkalemia. Now we learned what that means. If the iStats are highly specific, what does that mean? iStat is a good test. It's very specific for hyperkalemia because what? So is it good at identifying people with disease or people without disease? So specificity, so sensitivity means it finds people with disease, specificity without. So it's very specific, meaning if it's positive for hyperkalemia, it's probably accurate, right? So it's very specific for it, which also means it doesn't necessarily rule it out. If you suspect hyper K but it's negative, you want to find a sensitive test, not a specific test. So remember that the EKG is not always diagnostic for hyper K. People, I hear this all the time, especially medical students who are giving me a presentation. They say, yes, it's a blah, blah, blah. They've missed three days of dialysis. They feel weak and dizzy all over. But, you know, the EKG looks fine, so I'm sure we don't have to check a K. No. So in EKG, just like in acute coronary syndrome, an EKG is only helpful if it's positive, because half the time in acute coronary syndrome, you're not going to see any ischemic changes on an EKG. It's only helpful if you have ST elevation, et cetera. Likewise, in K, EKG is only sensitive for detecting hyper K changes. It's only got 35% sensitivity. So when it does show something, you should pay attention to that. And early aggressive treatment is indicated because of a very high associated mortality rate. So how do I decide whether to give calcium to a hyper K patient? I kind of look at them symptomatically, but I also make sure that there's no EKG changes for sure. Very often, if they look not so great, feel not so great, I'll give it. It's not gonna hurt them any, right? If they don't need it, great. They have stronger teeth and bones, but it's not, I especially give it first if they do have EKG changes. So what are the EKG changes? Well, it kind of depends on how high it is. So a pre-terminal event, just before they die, they get this sine wave pattern. You know what a sine wave is? Like that. That's a sine wave in physics. And when you see a sine wave on an EKG, that's not good. So, but the first thing you're going to see is peak T waves, typically one of the earliest findings. As it progresses, this is something to note. The peak T waves actually tend to decrease a little bit and get less peaky because it's like a string that you're pulling on each end. Right? It just kind of gets a little bit less, but it gets wider. And then when you really pull the strings on both ends, it gets sine wavy, and that's the pre-terminal event. So the degree of changes can kind of give you a general idea how bad the hyper-K is. But again, remember that it also kind of depends on how fast the K went up. Just like in hyponatremia, how fast the sodium drop is what really makes you sick. So rapid shifts in sodium or potassium both are not good, rapid. It's a little bit more tolerable. Like I will see dialysis patients who are often a little hyper-K. They kind of tolerate it in between dialysis sessions sometimes, and they can have a K of 7 and have very little, if any, EKG changes, maybe even, 6. I think the highest I've seen is 7, and they had maybe some widening of their QRS complex, but it wasn't anything like gigantic. So it really depends on the degree and rapidity of decline. Now, when you talk about hyper-K, there's really a 3-pronged approach to managing this, because you got to do this quickly if someone's symptomatic. You can, number one is stabilize the cardiac membrane, because that's what's going to kill them first. So the second thing is you want to shift the K out of the blood and back into the cell where it belongs. And then the third prong is get rid of potassium just in the body itself. So how do we do cardiac membrane stabilization? What's the number one thing we push? Calcium, very good. So calcium, in the presence of EKG changes, you can give a gram of KCl, of CaCl, calcium chloride, or 3 grams of calcium gluconate. Why do we triple the dose of calcium gluconate? Yes, there's less elemental calcium in gluconate. If you had a choice, why do we like gluconate?
It has chloride.
Oh, it has what?
It doesn't have chloride.
Well, that is the roundabout answer. The practical reason is because calcium chloride is pretty caustic. You know what that is? Like if it accidentally extravasates in tissue, it can cause tissue necrosis. It's painful, a lot of tissue damage. Ideally, calcium chloride goes into a large peripheral vein, if not a central line. Calcium gluconate is more forgiving. It's not as caustic, not as painful, doesn't sclerose the vessels as much, but you do have to give a little more of it because it's less elemental calcium. What cardiac membrane stabilization does is it allows sodium to go through the sodium-potassium pump like it's supposed to. It helps to stabilize that and lets you do the other temporizing measures while you're stabilizing the patient from getting a lethal dysrhythmia. Now, the way that you're now going to help drive potassium and shift it back in the cell where it belongs is there's a number of ways you can do that. One of them is insulin. You can give up to 10 units IV push, and then, of course, if they're not already hyperglycemic, which sometimes they are, in which case it's kind of 2-to-1 benefit there. If they're not already hyper, then you better give them some glucose behind that so they don't get hypoglycemic. And then that helps to pump the K back in the cells and reduce the serum potassium. Remember, that doesn't actually lower total body, it just shifts it back in the cells where it's supposed to be. So that's why the third prong of getting rid of the body potassium is going to be helpful too. So then albuterol, so same thing. Like insulin, does not decrease total body potassium, but it tries to help drive it into the cell where it belongs, and then give it with the insulin. So when I order this, I usually give the albuterol insulin and write them together on the orders that are given together. And then meds that will help remove potassium entirely from the body are the loop diuretics. So now we're using a side effect as a treatment. Remember, one of the side effects of being on Lasix is they get hypokalemic. And so people who take Lasix for CHF every day, we also see what on their med list? KDER, right? So potassium supplements. Well, this time we're using the side effect to our benefit. We give them lots of Lasix, they pee it out, they get rid of the potassium. So that kind of helps. And then sodium bicarb also helps to shift K back into the cells. And then K-exalate is a binder that helps deplete K as well. I will tell you that fewer and fewer and fewer hospitals and clinicians are using K-exalate because it doesn't bind as much potassium as we thought it does, and if it does, it's not really clinically relevant, but it does make for just a really, really messy bed in ER. So, because they poop it out. A much better one is Lokelma. This is a potassium binder that works in the digestive tract, pulls it from the GI tract, but it has been shown to work a lot more effectively as a potassium binder. You will probably see or hear about Lokelma, otherwise known as sodium zirconium cyclosilicate, if you're picking up a patient like to go to another ER or another ICU for hyper K or dialysis or kidney failure or whatever. You might report they also got 10 grams of Lokelma. Okay. Get it? Low K, Lokelma. So, I see what they did there? Yeah. So, other treatments. Remember that hemodialysis is the definitive management for life-threatening hyperkalemia. But you know how long it takes to get nephrology to see the patient, then call the techs and then hook them up and blah, blah, blah? It takes hours sometimes. So, I can't wait that long. We can't wait that long in the ambulance, so we can do temporizing measures. We can give them calcium, we can give them insulin, we can give them dextrose, bicarb, albuterol updraft on the way to the hospital, and stabilize them for the nephrologist to come in. So hypokalemia, we don't care so much about hypo. It's uncommon to have like a life-threatening hypokalemia, pretty common to have a life-threatening hyper. Nonetheless, just to round out our talk, anything hypo is less than 3.5. You can get this through too much insulin, too much diuretics. We all know this. Inadequate intake, not enough bananas, tomato, orange juice, whatever, large burns. Hypokalemia is pretty common among hospitalized patients, but it's not something that's going to cause any, at least unless it's super low, it's not going to cause any immediate emergencies. Interestingly enough, there are some EKG changes that might reflect hypokalemia. The quintessential one is the U wave. I think maybe in 30-some years I've seen 3 cases, maybe 4 of actual U waves from hypokalemia. It's exceedingly uncommon. But a U wave is after the T wave. So if you notice, for example, right here, this is a good one. You see the P wave, you see the QRS complex, you see the T wave, and then you're like, wow, this is a giant first-degree AV block. Well, no, it's not, because there's the P. So if that's a T, that's the P. What's that? Well, QRSTU. That must be the U wave. So that's a U wave. So you can see U waves. You can also more commonly see flattened T waves. I think I see that more commonly than I see U waves. Interestingly, in this one, the T wave is pretty normal, but then you see a U wave. Prolonged QT, sometimes ST depression. So this person had a K of 2, which is pretty low. Treatment is K runs or KDER. You've seen your patients on K supplements. So, all right, that's our whirlwind tour of potassium. Any questions on that? Cl, chloride, Cl minus, is an extracellular anion responsible for neutrality, helping offset sodium and potassium charges because it's an anion. It helps the kidney concentrate urine. Defined as a chloride more than 105 is hyperchloremic. Chad also had a cute little saying. If you remember, the normal chloride is 95 to 105. Well, chloride is kind of like chlorine in the pool. You go swimming when it's 95 to 105 degrees outside. Another little way of helping, right? So normal, 95 to 105-ish. Usually hyperchloremia is because of a chloride overload, like too much crystalloid, normal saline. people with DKA, for example, are getting tons of fluids. By the time you are clinically in DKA, about how many liters down are you from a dehydration standpoint? 1 or 2 liters? It's 5 to 9 liters by the time you're clinically presenting in DKA. You're pretty shriveled like a raisin on the inside. So, and it happens relatively. Why is that? Because they have polyuria. Right? DKA, sugar is a large molecule. Water follows these large molecules as a kind of an osmotic diuresis. They just go peeing and peeing and peeing all day, and they can't drink enough. So they're pretty volume down. Anyway, so we're dumping normal saline in them, and if we don't watch the BMP, sometimes they can get a little hyperchloremic. So they can get a hyperchloremic metabolic acidosis. Less than 95 is hypochloremia. Remember that chloride and bicarb are inversely related. We just had lunch. Now, on your BMP is CO2. Why is the HCO3 in parentheses? The bicarb in parentheses. Because are we actually measuring bicarb? No. But when you look at a basic metabolic profile, the CO2 value is a surrogate marker of your bicarb status in the blood. That may seem confusing until you think about what is the equilibrium equation for carbon dioxide and water in the bloodstream. Remember that bicarb dissociates into CO2 and water, and you get HCO3 as a result as well. So in this instance, because in the blood, CO2 and HCO3 are in equilibrium in the blood, when you measure a venous blood sample and get a CO2 level, it can represent HCO3. Does that make sense? So it's a surrogate marker, a pretty close surrogate marker. So when you look at the normal values, it's very, very close, 21 to 28-ish, and so now you're going to know that that lab value is kind of useful to determine degree presence of acidosis and alkalosis without necessarily waiting for an ABG or a VBG. So it's just one of those surrogate markers. So a low CO2 could indicate a metabolic acidosis or a respiratory alkalosis, so you're going to have to look at the whole clinical picture, and vice versa. If it's a high CO2, they may have a metabolic alkalosis or a respiratory acidosis. And so that might be a helpful marker for their acid-base status. That didn't last week, they go through acid-base? Okay, so this should just be a review for you, right? So just remember that when you look at last week's notes. The BUN is also on your BMP. That's your blood urea and nitrogen. Urea and water. Urea is formed in the liver, reabsorbed or excreted by the kidneys. And the thing to remember about BUN is that it is a marker of protein metabolism, whereas creatinine is, well, we'll talk about that next. So BUN, protein, just remember that linkage. Urea is related to the amount of protein intake and metabolism and excretion of that waste. So you would expect that BUN is part of kidney function, not just creatinine, because that's how it gets excreted. So if it's normal, the kidneys are excreting protein catabolism waste products normally. Normally, BUN does increase as we age. So if you look at all of you who are SCAD employees should have had your annual test already, or if you have it scheduled. And when you look at your lab results, it has a range of normals. It'll tell you what is your value, what is the range of normal. And in tests like this, where it can vary with age, like your creatinine also varies with age, it'll tell you what your normal is for your age, because they know how old you are. They'll say, well, for you, this is normal. For someone else, it's going to be up here or down here, depending on what your age is. So remember that an elevated BUN may be in the normal range for elderly patients, so just keep that in mind. If you have a low BUN, you can think of maybe they're overhydrated and they're just peeing a lot out, or they have malnutrition, they just don't get enough protein. If they have increased levels, they may have dehydration, something's wrong with the kidney because they're not urinating out, or they have increased protein catabolism, as in from burns. Or they eat a lot of protein too. So certain bodybuilders, you'll see they have a slight elevation in their BUN because they're eating 300, 400, 500 grams of protein a day with protein supplementations and steaks and protein shakes and blah, blah, blah. Plus, all that bodybuilding and weightlifting, a lot of protein breakdown and catabolism. So think about that. Creatinine is the other marker of kidney function besides the BUN, and this is more of a waste product of muscle metabolism itself. So BUN, more specifically, just proteins, creatinine, muscle breakdown. So the high energy phosphates break down into creatinine. It is very sensitive to kidney function. One of the slang terms for it is that it's the troponin of the kidneys, because it's very unique to kidney function. So this is how nephrologists will stratify the degree of renal insufficiency, not only through the glomerular filtration rate, but also creatinine level. You would expect someone who's having a creatinine of 3 versus a creatinine of 0.9, obviously the one with 3 has significantly impaired kidney function because it's the trope of the kidneys. When you consider the protein and muscle breakdown are related, that's why you look at the BUN creatinine ratio. The normal ratio is 10 to 1 to 20 to 1. Just to keep it simple, think of 15 to 1, kind of just right down the middle, as your normal ratio. What I mean by that, if you look at a BMP level and their BUN is 18, say, and their creatinine is 1.1, what is that ratio? Well, 18 divided by 1.1 is 16, so that's within the normal ratio of 10 to 20. If it's less than 10, you have a low BUN creatinine ratio. If it's more than 20, that's considered a high BUN creatinine ratio. How does that help you clinically when you're transferring an ICU patient to the ICU and you look at their ratio? Well, this table is probably, again, I'm a visual person, hopefully this helps you more than just numbers. So let's say that the BUN and the creatinine both were up. The ratio is the same, but they're both elevated. Now you're considering something wrong. There's kidney failure, obviously, but you think of a post-renal problem. What's an example of post-renal failure? First of all, what does post-renal failure mean? There's pre-renal failure, there's renal failure, intrinsic failure, and then there's post-renal failure. What do we mean by that? So the problem is after the kidneys? Okay. So can someone give me a clinical condition that would cause post-renal failure?
Or like, it was a problem, but then it was reversed?
No. In this case, I don't mean post as an after, like temporally. I mean physically.
Like an obstruction?
Obstruction, where? After the kidney, right? So anything after the kidney that's like obstructed, preventing the kidney from emptying, whatever, it clogs it up from the outside, so from the drain, not the intake, but from the drain, that's a post-renal failure. So, a what?
A UTI?
No, not usually, because it's infected, but it's still flowing. I'm talking like a renal calculi, although in that case, if they have 2 working kidneys and only 1 kidney is completely plugged in the ureter, you may not see a gross abnormality in the BUN and creatinine. Why? Because you still have 1 kidney that's working just fine. Yeah, so it would be something that affects both kidneys at the same time as post-obstructive, right? So I'm thinking, how about for dudes? How about for men? PPH, right? So if you have a complete obstruction of the urethra, that means both kidneys now are plugged up. It can't empty, and it backs up, backs up, backs up. Now you got hydroureter, hydronephrosis. The kidney's ballooning up because the pee can't get out. They've got 2 liters of pee in the bladder and counting. And then they go into kidney failure. That's a post-renal failure, okay? But why does both BUN and creatinine go up? Because both are excreted by the kidneys and both are being blocked, right? So think of it as, anyone see Beverly Hills Cop and what Eddie Murphy did to the tailpipe? He put a banana in the tailpipe, right? There's nothing wrong with the engine, but he put a banana in the tailpipe and it made the car that was tailing him fail. So that would be a post-engine failure, because the engine is fine, but the tailpipe is plugged. Kidney is fine, but the tailpipe is plugged, and so that's a post-renal failure. But now, if you look and see that the BUN is up, maybe the BUN is like 100, but the creatinine is normal. That's weird. What would that be? Well, that suggests something pre-renal is the problem. And the quintessential example of that is hypovolemia. So remember, blood is to the kidney what engine oil is to the engine, using our Axel Foley Beverly Hills Cop analogy again. So now, if you drain all the oil, if instead of putting a banana in the tailpipe, you snuck into the car, opened the drain plug, and all the oil came out, the car would still die because now it didn't have any oil, right? So the oil is flowing into the engine to keep it lubricated to run. The kidneys need a constant supply of blood to run. If you don't give blood to the kidneys, it will also fail. So a good example of that would be you get a major trauma, a motor vehicle crash out on I-70 and K, and their pressure is 70 and their heart rate's 140. They've lost all kinds of blood internally. You get them to Mercy and you check them on ESO the next day and looks like they're in a kidney failure. BUN's like 100 and their creatinine is, their ratio is up. It's 60 to 1 ratio instead of 15 to 1 ratio. Well, then now that's pre-renal. That makes sense because they were hypotensive and hypovolemic. And for 45 minutes, their kidneys were hypoperfused. The good news for that is that hopefully if you get the oil back in, if you give them blood transfusions, get crystalloid in them, and perfuse their kidneys, especially if it's a young trauma patient, very often their kidneys will come back online and they'll be okay. Some of them don't, though. That's what's sad about it. So that's an example of pre-renal. Here, if the BUN is normal, but the creatinine is up, giving you a decreased BUN creatinine ratio, now you think, well, maybe this is something intrinsic. So it's getting plenty of blood, and the tailpipe is not plugged. Something's wrong with the engine itself. Something's wrong in the engine, something's wrong in the kidney. That would be like rhabdo. So check the well-being. Neighbor says they haven't seen Miss Millie, their 80-year-old neighbor, in 3 days, and she's always out tending her garden. You look through the window, Sunfire will need to make a forcible entry, and you find her on the floor. She says, I fell 3 days ago. I've been yelling for help. Thank goodness someone noticed I was gone. What do you think? She's probably in rhabdo. She's been laying there. She's got sores, muscle breakdown, big molecules. It plugs up the coffee filters because there's such big molecules in the kidneys. The glomeruli are all gummed up, and she's in kidney failure. Well, that would be an example of an intrinsic renal failure. Does that make sense? Okay. So if you have decreased BUN, normal creatinine, the ratio is also decreased, just like up here. Maybe it's because they have liver disease. They're not synthesizing anymore. They're not eating any proteins. All they're eating is, I don't know, potato chips and whatever. There's no protein. Well, then that could be a cause as well. So these are just some prototypical examples of how do you use the BUN creatinine ratio clinically. Here you are. Glucose. I think everyone is pretty familiar with glucose and checking it, and low glucose is bad. Any questions? All right. Other labs of significance, calcium, mag, and phos. So the fishbone diagram for this one is calcium, mag, phos, clockwise in that order. We have mentioned calcium a few times already. There's free calcium, bound calcium, chelated calcium. The free or ionized calcium is what is physiologically active. So the first thing I do, if I have a lab value that is hypocalcemic or hypercalcemic, that alone doesn't worry me as much as what is the free calcium. So I will then order an ionized calcium. The reason why they don't do the ionized calcium all the time is because it's a little more expensive to run. And if the calcium level is otherwise normal, there's no real reason to do it. But if it's low or high, you want to see what the ionized or free calcium is. And so if I look at the ionized calcium, I want to see if it's low or high because that tells me if I should care or not. So roughly there's about a 50-50 distribution of total calcium, both free and bound. The ionized is the one, again, that's active, and that's what you care about because that's the one that participates in cardiac conduction. So that's why we care about free calcium. We don't care so much about the bound calcium because it's not going to do cardiac conduction. Ionized calcium, cardiac conduction. That's what's responsible for triggering muscle contractions, plays a factor in insulin release as well. So I definitely want to know what the calcium levels are. Now, hypercalcemia is not as clinically, I mean, yes, there are some clinical ramifications of hypercalcemia, but it's not that common. Of all the calcium disorders I might see, it's almost always hypocalcemia. If I do see hypercalcemia, it's almost always in cancer patients. Why is that? Can you think of a reason? Lots of cancers metabolize where? To what? The bones. What happens when the bones start getting eaten away? What happens to the calcium stored in the bones? The calcium stored in the bones gets eaten away, it gets leached out into the bloodstream. So whenever I see significant hypercalcemia, I'm worried about an undiagnosed cancer that's metastasized everywhere, or it's a known cancer patient that just has bone mets. So the easy way to remember cancers that spread to the bone, BLT with pickle, BLT, PK. So breast cancer, lung cancer, thyroid cancer, prostate cancer, kidney cancer. Those are the 5 that very often, if they metastasize, it'll metastasize the bone and cause hypercalcemia at times. BLT with pickle, breast, lung, thyroid, prostate, kidney. Most likely to metastasize, cancers that are most likely to metastasize to bone. And therefore, you worry about hypercalcemia. If they are symptomatic, you'll see things like lethargy, mental status changes, hypovolemia, coma. In that case, rapid fluid boluses to help dilute that out, as well as calcitonin can be given to help equalize calcium levels. Again, very uncommon. I think you could go your whole career without seeing a significant hypercalcemia patient. It is more likely that you'll see a hypocalcemia patient, however. Hypocalcemia is seen in pancreatitis, which is pretty common, right? Lots of people get pancreatitis. Lots of people get parathyroid gland dysfunctions. If you are significantly hypocalcemic, it can also cause some EKG changes. What is the EKG change that you, I'm getting ahead of myself. I think I'll talk about that in a second. But if you suspect that somebody is hypocalcemic, there is a physical exam that you can do that might help you detect it. One is called Schwazdeck sign. Schwazdeck sign is when you tap somebody just in front of their ear, their face twitches. See how his face is twitching when you tap? Okay. Contraction of the facial muscle, tapping the facial nerve just anterior to the ear. So right about there. The other one is Trousseau's sign. Trousseau's sign is carpal spasm when you occlude the brachial artery. So you pump up a blood pressure cuff all the way, you occlude the brachial artery, and their wrist will start spasm like this. Okay. That is Trousseau's sign, also a clinical indicator of, yeah?
Guys, whenever we show you a sign, and there's lots of them throughout the course, write them down in a special place because the board loves to test you on signs.
Yes.
All kinds of signs. So make sure you know them by heart.
Yeah, if there's a moniker or a special name for something, they love those. And I think it's just because it's easy to make a test question out of it. A first order question will be like, what is Trousseau's sign? Or Trousseau's sign is an indicator of what electrolyte abnormality. But the board doesn't use a whole lot of first order questions. They'll do a second order question. They'll say, you're taking a blood pressure of a patient, and all of a sudden their wrist kind of goes, wah, and they have painful spasms. Then they'll say, what do you suspect? So you have to already know what Trousseau's sign is, and then you have to know what that means, and then you have to know what abnormality that is. Okay.
Using medical terminology, like how would you, is it like what is it?
You can say carpal spasm.
Carpal spasm, okay.
Yeah.
Gotcha.
Yeah. Now, I knew I was going to talk about this. So hypocalcemia, if they have prolonged QT, they are at much higher risk of ventricular ectopy. So hypocalcemia, someone who's hypocalcemic, you really do want to give them supplemental calcium as soon as you can. The reason why the medical specialists on our USARD team know this is because we hammer this in their crush syndrome lecture all the time. You look for a tent on a desert. So hyperkalemia causes peak Ts, right? Hypocalcemia causes prolonged QT. So what does crush injury do? Well, it causes hyperkalemia from all the crush release of intracellular potassium, but crushed muscle also absorbs quite a bit of water and potassium. So crushed muscle will cause a relative hypocalcemia, and it will cause a relative hyperkalemia. So if you see a tent on a desert, a long QT and a peak T, then you should begin treatment immediately for both. And that's what they're looking for in the rubble pile. Okay?
Which is just calcium, right?
The cool thing is calcium is treatment for both. Isn't that cool? Yep, you shorten out the desert and you take that tent down and then you'll also do the other things like albuterol, insulin, dextrose. But yeah, calcium is the main medicine. You'll kill two birds with one stone. Mag is the other one. Mag levels, mag toxicity is probably the thing that you will see the most as opposed to hypomagnesium. And mag toxicity or mag hypermagnesemia is going to be in relation to OB patients a lot of times. It can also be used in seizure patients and sometimes in really bad asthmatics. So because it can be used as a bronchodilator and torsades, you can sometimes get mag toxic. So what is the big concern clinically for hypermagnesemia and mag toxicity? CNS depression, a drop in your blood pressure. In OB patients, the other thing it can do is cause respiratory depression. And if it's given as a bolus, like in eclampsia, for example, you give it too fast, they can stop breathing. So one of the early, what is the prototypical early sign of being mag toxic? What do the OB nurses check all the time when you got preeclamptics on a mag drip? Refluxes. So once their mag levels get dangerously high, they become areflexic or reduced refluxes, and then they'll titrate the mag down. Certainly if they get really symptomatic, they're going to get the antidote for mag toxicity, which of course is calcium and dialysis, but calcium is number one thing. The other electrolyte of note is going to be phos. Now, what's the difference between phosphorus and phosphate? Well, phosphorus is the element and it's just phos. Phosphate is the anion composed of phosphorus and oxygen, so it's PO4. So what we're actually looking at is PO4. That gets confused sometimes on quiz questions, so just know the difference. Phosphorus is the element, phosphate is the anion. Anion means it's positive or negative? Negative. By how many? How many electrons did it gain? 3. So it's going to be written PO4 3 minus. Okay. So phosphate is primarily located in the bones and cells. Tons of our foods contain phosphorus, and phosphates are involved in the metabolism of carbs, proteins, and fats. So it is an essential part of energy utilization, energy storage, calcium regulation, and RBC function. This is why if someone has a hyper or hypocalcemia, almost always the doctor will order a mag and a phos. Okay. People with new onset seizures, part of the workup is a mag and a phos because it is so intertwined as an essential electrolyte in membrane stabilization, energy utilization, et cetera. The next lab value that we'll look at is lactate. Now, we're going to spend a little more time on lactate because this is, for a critical care paramedic, lactic acid and understanding it is essential. This is one of the first tests that a doctor will order in a sick patient. Doesn't care what they're sick from. Just if they're sick, whether it's trauma or medical, a point of care lactate is one of the first things I order because it gives me a pretty good idea of how sick they are. Normal values, 0.5 to 2 millimoles per liter, that's the unit of measure, is millimoles per liter. Why is it not 0? How come why would a perfect normal not be 0? Because you need, well, I don't know the need, but if you're alive, you're going to be making lactate. Okay, so you're going to have some detection of it, and so it's part of the Krebs cycle and glycolysis. So there is no way, if you have a normal, if you're alive, that you won't have some level of lactate in your body. Okay, so this is a very highly stylized depiction of what we're about to talk about of lactic acid and lactate, because you can't understand why it's so significant until you understand this basic concept, right? So our body needs fuel of some kind, and the best, most efficient fuel is going to be glucose, right? Simple sugars. It's not fats, it's not just proteins, but you do need some glucose. That's the best, most efficient way for fuel. Normally, you have glycolysis, which is that aerobic or anaerobic? Glycolysis is anaerobic, okay? The clue is in the picture in that it's outside the powerhouse of the cell, so it's not part of the electron transport chain and Krebs cycle, it's outside of that, okay? It does produce a couple of ATP, so it does give you energy, but it's certainly not nearly as much as 38 ATP, but it is a quick way for your muscles to get some energy so that it doesn't have to go all the way through the Krebs cycle and electron transport chain. Krebs cycle, electron transport chain, there are even in there some options for making fuel without oxygen, but it's almost all going to be oxygen driven when oxygen is present. You follow so far? Okay. When we talk about lactic acidosis and lactate, a lot of people equate it to shock. What is the best what is your definition of shock? Hypoperfusion is a very common definition of shock. What else? What? Heart rate over, they probably are in shock, okay? So hypotension, so I got a hypoperfusion, I got a hypotension. What is your definition of shock? Hypoxia at the tissue, okay? There's my scholar. There's my scholar right there. The best definition of shock is hypoxia at the cellular level. If there's anything I want you to remember out of this entire semester, it's this slide, okay? Because paramedics, I dare say some of my interns don't quite understand this concept. Hypoxia, shock is hypoxia at the cellular level. It is not hypotension. Even if their blood pressure is 90/60, they might be in shock, but they may not be in shock. And if their blood pressure is 105/70, they may in fact be in shock. If they are well perfused, they may be in shock. Can you give me an example where someone is pink, warm, and dry, looks well perfused, their blood pressure is 100/60, and they're in profound shock? CO poisoning is one, right? Cyanide poisoning is another. Of course, in the later stages, they will become profoundly hypotensive and die. But I mean, early on, they're in shock, even though they're well perfused. Okay? We pull people out of fires, and they look shocky, but they're pink, warm, and dry, and their blood pressure is okay. It's not horrible, but they just got out of a fire. Okay? And modern construction tends to produce more cyanide than CO anymore. If it was just wood structures, sure, CO, but not a modern building. There's a lot of CO and CN, okay? Which is why if anyone looks shocky at all from a fire, we just give them hydroxycobalamin. What's the trade name for that? The kit? Cyanokit. Okay? So you can't say that it's low blood pressure or a lack of perfusion. They're often related, but hypoxia at the cellular level is the final common pathway. Whether it's anaphylactic shock, hemorrhagic shock, neurogenic shock, other distributive shock, the final common pathway is the cell isn't getting any oxygen. And that's what's driving your lactic acid production. So This is a much more accurate version of what this is. This is a nice cute cartoon, okay? If you want to know what's really happening, this is in your notes as well. This is what you kind of have to understand. And so here, when you see at the top, glucose, that's your main fuel source. Glycolysis is going to be turning that glucose into usable fuel in the form of ATP. Anaerobic pathways are this way, aerobic pathways are this way, and that's where the Krebs cycle and electron transport chain come into play. That's the most bang for your buck, where you're going to get way more ATP than the 2 ATP you get out of anaerobic metabolism. Glycolysis is where that's one of those side reactions that isn't up here, is where 2,3-BPG is made. So from this morning's talk, it would come off of that one, that side chain. Then that process is known as cellular respiration. So hold on to this thought as we go through this. Lactate is a measure of oxygenation, not perfusion. This is a key concept, so I'll say it one more time. Are you listening? Lactate is a measure of oxygenation, not of perfusion. And people get this wrong all the time. So if you understand this concept, you'll understand the rest of what we're going to talk about here. So remember, glycolysis, no oxygen is needed. You get a couple of ATP, but because as you go through the glycolysis process, lactate dehydrogenase is an enzyme whose byproduct is then lactate. Well, that buildup, the more anaerobic metabolism you have, the more of this byproduct you have, that's going to cause lactic acidosis. And the more as this builds and builds and builds and builds and builds, you're going to develop a high anion gap metabolic acidosis. And an acid base, last week, did you learn how to calculate an anion gap? Okay, so you know how to calculate an anion gap. So,
No, we're going to hold that for you in renal.
oh, in renal, okay.
That's when we do advanced ATP.
Perfect, okay. So we'll get to that. We'll calculate. It's very easy. You can look it up tonight if you want to. It's not rocket science. But anyway, you'll calculate a high anion gap, and that is one of the things that can cause that is a lot of lactic acid production. Now, if oxygen is present, then you'll go through the whole Krebs cycle, the electron transport chain, ending up with a lot of energy, 34 ATP in sum, and the sum total. But remember, all of that requires oxygen, okay? This is why lactic acid is a measure of oxygenation, not perfusion. Because if you don't have enough oxygen, you're hypoxic from hypoxemia, then you're going to get a lot more lactic acid production. Do you follow here? Okay. So as pyruvate gets shunted to the anaerobic system, you're going to be making more and more lactic acid. So lactic acid, the problem with that, though, is that it's not a great differentiator of where the problem is coming from, because, heck, anything that's in anaerobic metabolism can produce lactic acid. So, for example, lactic acid fermentation can be occurring in the muscles. It can be occurring at the erythrocyte level. It can be occurring at the liver level. So there's lots of different ways that lactate can come from. About 25% of it can be from skeletal muscle. So marathon runners, people who come in, they've just run 26 miles or what have you, or people that have just been exerting themselves a lot. Like I'll get athletes coming in, heat cramps, heat exhaustion, whatever, their lactate level will be pretty dang high. Skin and skeletal muscle put together is about half of where your lactic acid production comes from. Your red blood cells can produce another 20%, the brain, oddly enough, another 20%, GI system about 10%. So all of these places are sites where inefficient energy production can produce lactic acid. So when you look at lactic acidosis, you have to ask yourself, is this because I have inadequate oxygenation? Or is it unrelated to oxygenation per se, but underlying disease or other toxins or inborn errors of metabolism that produce lactate? And so type A, from inadequate oxygenation, we talked about the various forms of shock, septic shock, hemorrhagic shock, cardiogenic shock. We talked about carbon monoxide poison, which is just a simple, well, that's actually a chemical asphyxiant. What's the difference between a simple asphyxiant and a chemical asphyxiant?
The physical is more.
So give me an example of well, that would be a mechanical asphyxiation, right? If someone's strangling someone, that's like suffocation. But I'm talking about at the I guess it is at the cellular level. What is a simple asphyxiant versus a chemical asphyxiant?
But not giving enough oxygen would be that simple asphyxiant, and then sometimes hijack that place.
That is very, very close.
Is it like shunting?
Also close. It has to do with whether the cell itself is messed with. So a blood agent would be a chemical asphyxiant because it is messing with the cell. Cyanide is a classic example. Carbon monoxide is not allowing hemoglobin to bind oxygen, so it's messing with this hemoglobin itself. Okay, a methemoglobin. A simple asphyxiant means nothing's messing with the cell. The hemoglobin's fine and nothing's messing with it. It's being physically, oxygen itself is being physically displaced. Like carbon dioxide, helium, because a lot of fire extinguishers use that gas. What is it? Halon, right? Halon gas. Why does halon gas work as a fire extinguisher? Yeah, it doesn't do anything with cells. It just it displaces the oxygen. It takes it out of the air. It doesn't do anything to it, but it just places it out of the air. So if it just displaces the oxygen, that's a simple asphyxiant. If it doesn't displace oxygen, but it does something to the cell, it messes with the hemoglobin, it messes with the metabolism, that's a chemical asphyxiant. Okay? So these things, hypoxia, hypoxemia, anemia, that would be inadequate oxygen, a type A lactic acidosis. Notice that one of the most common meds that you'll be transporting is on this list, propofol. Propofol is a type B lactic acidosis because it's not so much oxygenation other than it's an exogenous toxin or drug. So if someone's on propofol for more than about 60 mics per kilo per minute for over 2 days, which if the ICU intensivist is not careful and like intentional about keeping track of how long they've been on propofol drip and how much are we at, that can actually cause a cascade of rhabdo, hyper-K, renal failure, lactic acidosis, and high NAGAP metabolic acidosis, dysrhythmia, and death. So we want to make sure. But notice all these other things are types of toxins. So even metformin, how many of your patients are on metformin? A lot, okay? Pretty much all of them. So what do you do for lactic acidosis? First of all, you want to direct it at the source. So why do you think they are acidotic from lactate? What is the source? If it's from propofol infusion, well, the first thing you do is stop the propofol, stop the offending agent. If it really is from inadequate oxygenation, then maximize their oxygenation. Probably one of the things that you're trying to do is optimize oxygenation to shunt away from anaerobic and go that other way towards Krebs cycle and electron transport chain, towards oxygen delivery. So give them oxygen and support their circulation. One of the mainstays of therapy is crystalloid boluses. So when somebody has an elevated lactic acid level, one of the first things I'll do is order at least a liter, if not 2, of a crystalloid infusion, just to improve their overall circulation at the same time of giving them supplemental oxygen to help their body choose the aerobic pathway over the anaerobic pathway. Make sense? Now, I always get this question, hey, you know, they're pretty acidotic and the lactate's like, should we just give them some bicarb? You know, that'll be a good buffer. What about bicarb in acidosis? And I gotta tell you, one of the most irritating things I see all the time is, because it's not in my protocols, and it won't be in the update either, of giving bicarb in cardiac arrest. A lot of people like to do that. But man, we just saw what the mathematical equilibrium formula is, and bicarb almost immediately gets metabolized into water and CO2. So unless you have a bicarb drip, you're not alkalinizing the blood and reversing acidosis. Okay? This is why also in USAR, if we're trying to alkalinize someone's urine to help them get the rhabdo unplugged from their kidneys and restore kidney filtration and flow, we don't just give them bicarb. We give them bicarb and we start a bicarb drip so that it stays alkaline, and we try to alkalinize the urine to help get rid of all that crap in their nephrons and glomeruli. Even that is a little bit controversial because now they're thinking, well, it may help, but it may not, either not a whole lot of great evidence. However, for bicarb, we've had 2 decades of studies for bicarb in lactic acidosis. And there's no evidence for its helping no matter what the degree of acidemia is. There's some evidence for patient harm, in fact. So we're not going to give bicarb just because they have a high lactate. What we will do is give them oxygen, we'll give them fluids, we'll direct it at the source of their lactic acidosis. If it's sepsis, they'll be getting antibiotics. If it's a big abscess, we'll drain it. We'll go for the source and we'll treat them that way, but we're not going to give them bicarb.
Directed more towards renal protective.
For crush syndrome, yes. Sorry.
Trying to alkalize and dilute the urine from all the solute.
It's not so much diluting, it's alkalinizing. Because the theory behind it is that an alkaline urine makes the globulins that are plugging up the glomeruli more soluble, supposedly, and it helps it flush faster out of the kidneys and unplug the gummed up gum works from all the cellular debris and protein. So that's why that is, and not so much the acidosis. That's pretty high. Yeah, sure. Yeah, that's why. That's why. Okay, folks, thank you for coming back. We have 2 hours to get through 107 slides. 3? We have till 5? Oh, I thought you said we have till 4. Okay. Well, no problem then. All right. Well, shoot. Okay. All right. In that case, we can slow down. I'm kidding. I will get you out of here on time by 5 o'clock. Okay. So, respiratory emergencies. Let's start with a case study. 67-year-old guy comes in for shortness of breath. He's in the emergency department. You transported him. He feels short of breath. His oxygen is about 2 liters per minute by nasal cannula. FiO2, therefore, is about 24 to 28%, depending on what you read. There's his ABG. There's his vitals. There's his SATs, 84%. He's almost hit a fever of 99.7. So now you're thinking, okay, what could be wrong with him? Well, shoot, your differential should be like 20 things this could be. But there are some things on there that should be concerning to you. And what are some of the things that might be concerning to you on there?
So it looks like he's respiratory acidosis.
Okay.
It looks like his kidneys are not doing anything. Those 2 sats too. We've got him on, you said he's on oxygen.
2 liters. If you checked his lactate level, would you expect it to be normal or high or low? If anything, it might be high because he's not oxygenating really well. Okay, good. So just kind of some things to think about. If his condition were acute as opposed to chronic respiratory problems, you would expect his pH to fall using the following formula. If you take the PCO2 minus 40 divided by 10 and multiply by 0.08, that turns out to your calculations of 0.096. So minus that from a normal pH of 7.4, you would expect him to be a 7.304. And in fact, his pH is 7.3. So if you had to guess, this probably is some sort of an acute problem, not a chronic problem. Now, he may have some measure of underlying disease. We don't know that. I didn't give you that, but given that he is acutely short of breath, that should help solidify your pre-hospital diagnosis of, hey, I think this is not just his baseline COPD or whatever. I think this is probably something acute. So before we go and talk about the specific pathophysiology of stuff, I will have to tell you, especially in medicine, words mean things. So let's do some vocabulary lessons first really quick. Hypoxemia and hypoxia. People use this term interchangeably all the time, and they're not the same thing. They're very related, but they're not the same thing. So what is hypoxemia? Hypoxemia is a low partial pressure of oxygen in the blood, right? It is a specific and measurable marker of oxygen in the blood. Hypoxia, however, is kind of more of a general, less specific or nonspecific term. Hypoxia means inadequate tissue supply or utilization in the tissues. That's any tissue. Get the lungs, kidneys, skeletal muscle, brain, inadequate utilization supply of oxygen in the tissues. Okay. Hypoxemia is blood. Causes of this hypoxia. The number one cause of hypoxia is in fact hypoxemia. So you have low oxygen in the blood, you're going to have low oxygen everywhere else in the tissues. Lung problems. We had a very nice discussion this morning on VQ mismatching, which we'll talk about a little bit more in a few minutes. We have low FiO2 conditions like high altitude, simple asphyxiants, and confined spaces, and we talked about chemical as well. Anemia, hemoglobinopathies, histotoxic hypoxia is a fancy term for a chemical asphyxiation like cyanide or CO, for example. So lots of causes for hypoxia. When we talk about CO2, we'll talk about hypercapnia and hypercarbia. Those two are also often used interchangeably. It turns out that's okay. They really are synonymous. Hypercapnia and hypercarbia both mean increasing carbon dioxide somewhere in the body. So why do we have two different names for it? Well, like in medicine, we have different roots. So one is Greek root, one is Latin root, but it doesn't matter. Excess CO2, you want to say hypercarbia, hypercapnia, great. The take-home message is this, that if you have too much of it, that's no good, right? So you have little to no symptoms, or you can progress. You can get headache, dizziness, fatigue, seizures, and eventually with super high CO2, LOC, coma, death. So hypoventilation. What are some causes for hypoventilation? Yes. So central respiratory depression, so something in the respiratory center of the brain. You could have some neurological muscle weakness. Obesity, hypoventilation syndrome, or Pickwickian syndrome. They're so big that they mechanically cannot do diaphragmatic excursion and chest excursion enough. Low minute ventilation on the ventilator. Maybe you have set the tidal volume too low, maybe. Okay? So these are all multiple things that can cause hypoventilation. We talked, in fact, about one of the neuromuscular ones like myasthenia gravis. We mentioned that. The other one being, what is the one where it's an ascending paralysis? No, it's a French word.
Yeah, Guillain-Barré.
Yes, Guillain-Barré, ascending paralysis, and if it hits the diaphragm, guess what? You can't breathe anymore, and some of those patients end up being on a trach and a home ventilator. Okay. The next vocabulary word we want to talk about is diffusion. We had a very nice discussion about diffusion this morning. Okay. The net movement of anything generally from a region of higher concentration to a region of lower concentration. So the gases O2 and CO2 diffuse from higher to lower concentrations, as we discussed today. When you talk about this process of diffusion, it is remarkable what happens at the cellular level. You know, your blood spends only 4 or 5 seconds in the pulmonary vascular circuit to begin with, but at the alveolar capillary interface, it's less than a second. It's like 0.75 seconds. And if you're tachycardic, it's even faster. It's like 0.25 seconds. In that, I mean, this is a highly slowed down version, obviously, right? It's just a speed bullet train going through there, picking up oxygen, dumping off CO2 at the respiration school district. That was cute. I love the school bus. That is a speedy bus driver, right? So less than a second where diffusion and gas exchange occurs. When we talk about ventilation and perfusion, the one thing I wanted to kind of adjust from this morning's presentation was, I think this morning's presentation said something about Q or perfusion being the exchange of oxygen and CO2, or more related, it was something about gas exchange. Just to clarify a little bit, perfusion is, it's blood flow. When we talk about VQ mismatch, we're talking about pulmonary blood flow. It's not necessarily the exchange of gases, because what we're talking about there, that's respiration, right? External and internal respiration. So when we're talking about VQ mismatch, all we're talking about is V is air going in and out of the air sacs, the alveoli, and Q is blood going around and around those air sacs. And that's it. It really doesn't have anything to do with gas exchange. So it's a delicate balance, obviously, between V and Q. It's got to be a symphony of movement of going around each alveolar sac, the blood flow, and the blood flow flowing freely. So as that merry-go-round goes around this alveolar sac, and blood is picking up the waste product and dumping it off into the alveoli, and then picking up oxygen to deliver to the tissues, that delicate balance is the alveolar gas exchange balance. When we look at the VQ ratio, again, nicely done this morning, when you consider that the ventilation amount reaching the alveoli is about 4 liters per minute, and the Q portion, the perfusion, is about 5 liters per minute at a normal resting cardiac output. You'd run the VQ ratio at 4/5, and that's about 0.8. So generally, if you have a V problem, and now it's 2 instead of 4 with 5 liters per minute, you have a decreased VQ ratio of 0.4. It's decreased because it's not 0.8. It's less than 0.8, so it's a decreased ratio. I don't know if your textbook does this, I should have looked, but I have seen other textbooks that incorrectly call this a decreased VQ mismatch. That's not a decreased VQ mismatch, that's a decreased ratio. Whether you have an increased ratio or a decreased ratio, it's a mismatch because it's not 0.8, you understand? Yes. So a decreased mismatch means you're doing something to make the patient better and you're getting it closer to 0.8, that's a decreasing mismatch. Or it's 1.2 and you're getting closer to 0.8, that's a decreased mismatch. Okay. So mismatch and ratio are not the same thing, and I've seen some books and some lecturers talk about ratio and mismatch like it's the same thing, and it's not. So decreased ratio is a VQ mismatch. Okay? Now on the other end, what if our ventilation is fine, it's 4, but now our perfusion drops because of whatever. It's now down to 3. Well, now 4/3 is 1.3. Now it's more than 0.8. That is how would you describe that? That's an increased ratio. Okay, that's an increased ratio. So a mismatch is anything that isn't 0.8. You follow so far? Okay, great. So now identify the problem. What is the problem here? Is it a V problem or a Q problem? This is a V problem because there's a blockage of some kind to the alveolus. And over here, the alveoli are wide open, but this blood vessel is blocked with something or reduced flow. It doesn't have to be a blockade, right? Because in this morning's presentation as well, they talked about how the bottom of the lung and the top of the lung have different VQ ratios, total. Okay? It all kind of evens out, but why is it that they're different? Why is there more Q at the base of the lung than the apex? Because when you're standing, gravity dependent, right? You're going to have more flow here than you will up top. So good. So there's the problem. It's a V problem or a Q problem. There's lots of causes for VQ mismatch, so you should know some of the V problems. So a decreased VQ ratio from V problems, ventilation problems, could be from like asthma, pulmonary edema, or chronic bronchitis. What's the deal with asthma? Why is that a V problem? Right, because the alveolus is not getting, sections of the alveoli are not getting O2 because of how severe the bronchial constriction is. Believe it or not, There are patients who still die from asthma attacks. I know in this modern day and age, how is that possible? People still die from asthma, okay? So it constricts so much that the alveolus it's not being ventilated. It's not getting any air, but the flow is the same, okay? Well, how is that different from chronic bronchitis? Because the pictures look similar. What is the difference between asthma and chronic bronchitis? Chronic bronchitis adds some gooey mucus to it, okay? So an asthmatic with chronic bronchitis, that's even worse, okay? So that's bad. A lot of phlegm being, I got patients all the time tell me that. I got lots of phlegm, okay. How about pulmonary edema? Where's the problem there? Now that is in the alveoli itself, right? Because outside it's the immediate tubes leading to it, but in pulmonary edema, you can see the air fluid levels in the air sac itself. So wide open tubes to it for now, but then it's filled with gunk, consolidation, fluid, pus, whatever it is. Then you have Q problems. So you have an increased VQ ratio because the alveoli are fine, but there's something with the flow, okay? Now, we talked about chronic bronchitis over in the decreased VQ, and here we have emphysema in the increased VQ. But they're both types of COPD. So why on earth is chronic bronchitis a V problem, but emphysema is considered a Q problem?
Because in emphysema, there's the alveoli are like stretchy, and they don't have much elasticity. So the air can get down there. The alveoli aren't filled with fluid and pus, and the air can get down there, but also the alveoli don't fill back. I feel like a paramedic and not a critical care paramedic right now.
That's okay. That is okay. Listen, I love it that you're not afraid to jump in there and give me an answer. Very, very close. So she said that there's very little elasticity, okay? But yes, that's what happens. So if you look real close at the picture, in emphysema, the alveoli itself are damaged, right? It's like this flimsy plastic grocery bag from the store. Very compliant, very easy to blow up the bag, but there's little, if any, elastic recoil. It's deformed and bloated like that, right? And you can see that if you can imagine the capillaries that wrap around a normal alveolus, what happens to it when it gets all deformed and bloated and stretched out like that? Is it squished or is it more open? It's squished. It's squished or destroyed. So yes, you're right, there's air going in it, but the air can't get out for one thing, but it's more of a Q problem because the flow around those alveoli are also disrupted. So that's one thing that people think of emphysema more as a V problem, but it actually isn't. Chronic bronchitis is. Emphysema is more of a Q problem in the balance of things because its flow is highly disrupted. What am I trying to depict here? It could be VFib. It could be. It also could just be CHF. Really bad overall global hypokinesis. So in other words, if the lung, if a part of the lung is just not getting flow because the heart isn't pumping forward enough, the cardiac output is reduced, but you're still on a ventilator, for example, and you're breathing, that's a Q problem because it's not getting flow. And of course, the prototype Q problem is a pulmonary embolism, right? So you've got plenty of air going in and out of the lungs, but there's a giant clot and a whole piece of lung is not getting any blood because of this giant pulmonary embolism. So very much of an increased VQ ratio, and so a horrible VQ mismatch. So, I already mentioned this already, my pet peeve. It's not a decreased mismatch, it's a decreased ratio. It's not an increased mismatch, it might be increased mismatch, but what they mean is an increased ratio, okay? So ratio and mismatch, not the same thing. So, another term often misused is dyspnea. As one of my soon-to-be critical care paramedics, you gotta know what dyspnea means, okay? First, it's not dyspnea. The patient is very dyspneic. What are they, dipping some chew? No, it's dyspneic, okay? Dyspnea is a sensation. It's a feeling of inadequate or trouble breathing. There may be absolutely nothing wrong with them. They're having a panic attack, but they feel like they're suffocating. They're still dyspneic, okay? Because it's a subjective feeling. It is an uncomfortably abnormal awareness of the act of breathing. That is dyspnea. It is not a sign, okay? What is a sign? A sign is a physical manifestation that you can see, okay? A symptom is something that they tell you, that you can't measure and you can't see. Someone says, I'm tired, sign or symptom? Symptom, okay? They're laying there like this, can't open their eyes, that's a sign. But you can't say they're showing signs of tiredness. You're gonna say they're lethargic, they're obtunded, okay? You don't say, they look dyspneic. You say, they have nasal flaring, intercostal retractions, hyperventilation, tachypnea, accessory muscle use, tripoding, right? But they don't look. It's better to say the patient reports dyspnea and they exhibit tripoding and intercostal retractions and tachypnea. Perfect, perfect. Okay, words mean things. So if one of these patients were dyspneic, which one would be merely symptomatic? The second one, because the rest of them are like, they've got a sign, right? There's actually a name for this sign. If somebody has chest pain and they make a fist in front of their chest, that's Levine's sign, okay? Levine sign, okay? That's a sign, okay, of acute coronary syndrome. I don't know if there's a sign for this, but that's a sign usually when people do this and pat their chest, that's a sign that they feel short of breath, okay? So this lady, though, she says, okay, I'm short of breath. Well, I'll have to take her word for it. She looks more depressed than short of breath, but anyway. Acute respiratory distress. So recognition of respiratory distress. These are signs you're looking for, like tachypnea, muscle usage, cyanosis. They've got wheezing, stridor, rales. They've got syncope from hyperventilation. Dizziness is actually not a sign, right? That is a symptom, okay? But syncope is a sign. Tripoding, coughing, hemoptysis, these are things that you can see. These are outward signs, okay? So lots of causes of dyspnea. There's a whole list there. Anxiety can cause it too, but that's always a diagnosis of exclusion, right? We never diagnose somebody with a psych problem. We rule out medical problems first. Broken ribs. How come broken ribs can cause dyspnea? They hurt, and you guppy breathe, right? Lung conditions, allergic reaction. By the way, what is wrong with this photo?
No chamber.
There's no aero chamber. Thank you. There's another scholar. No aero chamber. It's like selling a car with no steering wheel. Like an aero chamber steers the medicine into your lungs. Okay? Your stomach is getting beta-2 agonists, but your lungs aren't. Okay, so you got to have the aero chamber. That's my little pet peeve. All right. How can these labs give us clues as for the etiology of dyspnea? We just spent all morning talking about labs. Someone says, man, I'm kind of short of breath. I don't know why. No one can figure out why. What clue might suggest, hey, I know why you're short of breath. It's because your CBC shows a hemoglobin of 5 and a hematocrit of 15. Okay? No wonder you're short of breath. All 8 of your red blood cells are trying to oxygenate your whole body, all right? A hemoglobin of 5, all right? How about on a BMP? Okay, there's one in particular that might be, you could tie in to shortness of breath. That's not on the BMP. There's only 7. Which one of the 7? Think about it. I know you can come up with it. I know you can. This is a third order test question. I need thinkers. Oh, you said what? You said it. Creatinine. Why would an elevated creatinine, how would that explain shortness of breath?
Because it's muscle breakdown.
Could be. What? Well, maybe not the creatinine alone. So let me back it up. If they have an elevated creatinine of 5, for example, by definition, they are in renal failure. So if the kidneys are not making urine anymore, what's happening to their volume status? Hypervolemic. And if the volume has no place else to go, where does it back up into? The lungs. So now they're in pulmonary edema, and oh my goodness, they're short of breath because they have pulmonary edema. They have a V problem because their alveoli are full of fluid. Very good. How about the BNP? First of all, what does BNP stand for? N as in Nancy. BNP. So you got 2/3 of it. Natriuretic peptide is the NP. What's the B? B type? Blood? Base? Nope. Boring. Brain natriuretic peptide. Interestingly enough, BN peptide is a measure of CHF. If it's elevated during congestive heart failure, pulmonary edema, shortness of breath. Good. How about blood gases? Well, that's easy. Blood gases, right? If they have a respiratory acidosis or alkalosis, there's something wrong with that's why they're having shortness of breath. How about lactate? You kind of alluded this. You said lactate, yes, but it's not part of the BMP. But lactate, why would that be a marker of shortness of breath? Maybe they have anaerobic metabolism. They're not, something is blocking their body from using oxygen, so they're short of breath perhaps. They're hypoxic and hypoxemic. Good. How about troponins? Yeah, an MI will cause shortness, okay? And finally, D-dimer, how about that? PE, good. Usually a blood clot, if they're short of breath with an elevated D-dimer, they have a blood clot in the lungs until proven otherwise. Right? That's a PE, very good. So, how do you know where the problem is if they have hypoxia or hypoxemia? Well, the cool thing is there's this formula called the AA gradient that you can calculate that helps suggest whether their problem is in the lungs or is it outside the lung. Is it intrapulmonary or extrapulmonary? And if you have a patient where, man, they are hypoxic, but I'm not sure why, or they have a degree of hypoxia that you can't explain, like they're breathing fine, and I don't know why their sats are 82%. I just can't explain it. They're not sick or anything. Then you can get the AA gradient, and that helps you decide, well, is this a lung problem or is it outside the lung is my problem? So the question then becomes, well, how do you calculate it? Well, there's this handy-dandy mathematical formula. And of course, whenever there's a mathematical formula, oh, that's a favorite type of test question, right? Because all you do is plug in the numbers and get you an answer. So the AA gradient, the big A, little a, is a measure of the alveolar gas equation, your partial pressure of oxygen as calculated by the alveolar gas equation, minus the P little a O2, which is you actually measure from the ABG. So that's easy, right? Get an ABG, what's the PaO2, plug that number in. The hard part is getting the P big A O2. What the heck is the alveolar gas equation? Honestly, there have been several iterations of it from pulmonology through the years. It has been greatly simplified, believe it or not, to the modern alveolar gas equation. And this is the simplified version, yes. So your big P big A O2 is FiO2 multiplied by the atmospheric partial pressure and the partial pressure in the alveoli, which typically at normal temperatures is 47 millimeters of mercury. So there's your constant, okay? So your two constants at sea level, it's 760 torr, right, or millimeters of mercury. You remember that from high school physics. Minus 47, which is 713, if you, in case you don't have a calculator on you, okay? So then you subtract that from the PaCO2 from the ABG over the respiratory quotient, which is another constant of 0.8. Don't ask me where they got that constant from, but that's what the constant is.
I'm just glad they made it.
We covered this last week, Dr. Tan. I don't know if you're aware.
Oh, I didn't know you covered this already.
Yeah, we already covered it, and I think. Huh?
PF ratio.
But he did just answer the question if TOR is the same as.
Yes, he did.
pulmonary mercury.
We went over the AA. No, that's what I'm saying. I gave them a simplified equation for the AA gradient.
Oh, okay.
We did cover this, guys.
Let's all agree with Brian, yes, Brian.
Because, but then I said we went to the PF ratio after this, PF ratio after this, remember?
Sure.
We covered that.
So the reason
We went through two problems on the board.
We believe you.
the reason why it's in my slides is because it was in the week 3 slide, so I included it. So I'll go through it real quick then as a measure of since you went through it. This is just This will be a quick review then.
He said when we did
So-
it, he would cover this a little bit more again, where we're getting a head start.
He's gonna cover the same thing I covered, so if you wanna go through it again, you can, but it's the exact same stuff we covered already.
You want to do a quick review?
Oh, yeah.
Okay, we'll do a quick review. Since you went through it on detail, we'll just do a quick review. So if you remember from last week, the simplified version, if you plug those numbers in, a normal person should have a P big A O2 of about 99, okay, 99 to 100, okay? But to be specific, it's 99 millimeters of mercury right here. So then, now you know how to plug in the AA gradient. The AA gradient is age over 4 plus 4. So if you're 30 years old, a normal for you would be 11.5. 90-year-old, the normal will be 26.5. So that's how the AA gradient then is then calculated, okay? So now, when you have hypoxemia that you can't explain, and you have a high AA gradient, now you think, well, it could be dead space, PE, hypotension, pulmonary hypertension, vasculitis. It could be a shunt, either a physiologic shunt or an anatomic shunt. An anatomic shunt means the body is physically malformed, like there's an AVM or an intracardiac shunt. All the oxygen in the world won't fix it because that shunt exists, mixing oxygenated and deoxygenated blood. But if it's a physiologic shunt, that means the pipes are okay. There's something messing with it though, like pneumonia. Once you get rid of the pneumonia, everything's fine. Don't get the pneumonia. Edema, atelectasis, diffuse alveolar hemorrhage, things like that, okay? You can also have impaired diffusion in the form of interstitial lung disease. Those are all high AA gradient conditions. If it's low to normal, you might have hypoventilation or simply reduced FiO2. But then that is extracardiac and intracardiac. I mean, extrapulmonary rather, and pulmonary. So this would be high AA gradient suggests that your problem is somewhere in the lungs. Whereas a normal AA gradient is somewhere, the lungs are fine, but you're at 15,000 feet. And you have a low FiO2, okay? Something like that. Makes sense? So then you can also calculate the PF ratio. Sounds like you went over this last week too. So another, just a quick review, is this is an indicator of the shunt fraction. So PF ratio is your P little AO2 over FiO2. So if you calculate someone's ABG and their ABG is 87 and they're on room air, which is 0.21, then you have a PF ratio of 414. And guess what? Anything more than 400 is considered normal, okay? Once you get to less than 200, that's a critical respiratory failure, okay?
But is that, I think last week we had 300.
Well, 300 is respiratory failure. 300 is the cutoff for respiratory failure. I'm saying 400, 250 is severe, and 200 is critical.
No, my chart was different, Dr. Tam. My chart showed anything over 300 is within normal range.
Okay, okay,
Up to 400 being optimal.
yeah,
Low is bad.
low is bad. Yeah, I'll have, yeah, low is bad, higher is good, okay? So a PaO2 of 87 is considered normal, and 21% on room air. So 414 is definitely more than 300. So that's good, right? So Chief Stewart will let you know what chart to use as far as test questions go, as far as what the cutoff is going to be. But suffice to say, definitely more than 300, you're not respiratory failure. Less than 300, you are respiratory failure. That we can agree on. Okay. So if this guy has a PaO2 of 80 at 50% Venturi mask, then his score is 160, which is pretty dang low by anyone's account. That's going to be respiratory failure. Okay. The definition, the Berlin definition of ARDS, I don't know if you went over that, the Berlin definition of ARDS. Okay, so, you know, at 160, this would be considered a moderate ARDS. Okay. Now, insufficiency, depression, and failure. This is another area that I want to just highlight because insufficiency, depression, and failure, you really should have a pretty good idea of what that means. So respiratory insufficiency is when you start outpacing your body's metabolic demand for whatever reason. So either it's a ventilation problem or it's an oxygenation problem something your respiratory system can't keep up with demand. Once you start progressing, you can start degenerating into respiratory depression or bradypnea, and that's pretty bad. If you need to be hyperventilating, but you're so tired now or it's prolonged that you have a normal or low respiratory rate, you're going to spiral down to failure pretty dang quickly. And failure is when the respiratory system absolutely fails to meet metabolic demands. So a failure of ventilation, usually a PCO2 more than 60, PO2 less than 60. So that's kind of easy to remember, 60 and 60, more than 60, less than 60. What about end-tidal CO2? If the PCO2 is more than the end-tidal by 5 or so, you can also consider that a marker of respiratory failure. Now here's an interesting thing. There's also a discussion about respiratory distress versus respiratory failure. Here is what looks to be a pretty reputable post that says respiratory distress is when a person is unable to regulate gas exchange, causing them to have either too little oxygen or expel too much carbon dioxide. But respiratory failure can follow respiratory distress, causes more severe difficulty with gas exchange, which left untreated can be fatal. And I'm like, and this is an example of how I don't think the internet is always helpful or trustworthy. So is distress a sign or a symptom? Well, dyspnea is definitely a symptom. If someone's in distress, that's a sign. Like I can see that someone's in distress. I can't see that they're short of breath, but I can see that they're in distress. So to me, this definition is a little bit strange. I started by saying words mean things, right? So I think if you use insufficiency and distress, it's probably better to say that distress is a sign of respiratory insufficiency, but it's not necessarily the same as failure. I want to be very clear that when someone starts having altered mental status, they have crossed a line into respiratory failure. If someone's wide awake and they're otherwise okay, they may be having some distress, and certainly distress from insufficiency. Can you see where can you follow? But they're still mentating just fine. They know we're there, they know what's going on, they're trying to answer your questions. But if you get on the scene and they're like, somnolent, or they're confused, they're like, get me out of this grocery store, and they're in the hospital, right? Now they're altered. And to me, now this is frank respiratory failure now, to the point where they're altered, okay? So I like this as kind of a better continuum. Respiratory insufficiency, distress, and failure is a continuum. It's like heat illness, right? There's no such thing as just heat exhaustion and heat stroke. It's a continuous disease with very blurry boundaries. But once you cross mental status changes, it ain't you're sweating or you're not sweating. That's not it either. It's you're lucid and then you're confused. The minute you become confused at all, you're in heat stroke. The minute you become confused at all, you're in respiratory failure. Okay? So you can have tachypnea, tachycardia, paleness, stridor, wheezing. These are all signs of insufficiency. You can be in distress. But once you become a little agitated, you're on that really blurry line between respiratory insufficiency and failure. Once you become altered, however, and certainly once you become decreased, you become somnolent, that is respiratory failure. You follow? Then you can get cyanotic, hypercarbic, tachypnic, fatigue. Then you become bradypnic, or slow respiratory. That's pre-terminal. They are about to code. And then you code, and you go into respiratory arrest. Can we fix that? Sure can. Okay, we can breathe for them. We can bag them. We can intubate them. We can fix that. Then we have to find the underlying cause of what's causing the respiratory failure. So several types, if you want to categorize it, of respiratory failure. It can be hypoxic or failure of oxygenation. So hypoventilation, VQ mismatch, what have you, PO2 less than 60. It can be hypercarbic, failure of ventilation, okay? So your CO2 is greater than 60, pH is acidotic, COPD is a good example of that. The problem, the O in COPD, obstructive, trouble with getting air out. trouble with overcoming resistance, and so you want to try to open those airways as much as you can. Things like albuterol, positive pressure ventilation, perhaps can help get rid of some of that obstructed air. Type 3 is a mixed, and you can see this in post-op patients where they have atelectasis and they just need some pulmonary toilet, a little bit of incentive spirometry, cough, get all the phlegm and junk out, and they can reverse that atelectasis. And then type 4, shock, hypoxia at the cellular level, this time from hyperperfusion from any reason like sepsis, hypovolemia, cardiogenic, what have you. Identify and reverse the cause, and you identify and reverse the respiratory failure. Remember that these are not necessarily indications for intubation, other than you better watch them closely, and if in fact they are not able to protect their airway or their CO2 is getting worse and worse and they're just getting more obtunded, then if it's inevitable, then you can take their airway. But this alone, if you can reverse it, you can save an ICU admission and save an intubation. So if we go back to our case study, here's this guy, here's his numbers. We said he's 67 years old, so what is his normal AA gradient? 20.75. It would be his normal. Okay? So how do you calculate his AA gradient? Is the P big A O2 minus the P little a O2. We calculate from the PaO2 equation 137.5. We said his PaO2 was 50 divided by the respiratory quotient, so his AA gradient is 75. So is it high or normal? High. So is it outside the lung or inside the lung? It's inside the lung. It's probably dead space, shunt, or impaired diffusion. It turns out, remember we said he had low-grade fever, he was hypoxic. His chest x-ray result just came back, or no, you're transporting him to the ICU, to the hospital from the nursing home, and they say, hey, you got a chest x-ray this morning. It shows a right middle lobe pneumonia. Well, that matches all the numbers, doesn't it? Because now we know that he probably has a physiologic shunt from PNA, pneumonia. So it all matches. Now, if you'd like to calculate the shunt fraction with this PF ratio, then you can do the P little a O2 over FiO2. We said he was on 28%, or 2 liters nasal cannula, 50 divided by 0.28, 178. That's going to be pretty low by any gauge. So he's in pretty bad respiratory failure. So when you talk about, we talked about COPD a lot. How about restrictive lung disease? Well, the problem with restrictive lung disease, as opposed to obstructive being a problem of getting air out, in restrictive, the problem is, in fact, getting air into the lungs. So you have conditions like pulmonary fibrosis, pneumonia, Guillain-Barré, and Lou Gehrig's disease. We mentioned that already. These are problems getting air in, often from decreased lung compliance. They're very stiff. So as opposed to COPD, like emphysema, where compliance is very high, but elastic recoil is very, very low. In pulmonary fibrosis, it's the opposite. It's not like a COPD, which is like a grocery bag. This is like one of those thick birthday balloons. Low compliance, stiff, but it has what? A lot of elastic recoil. High compliance, low recoil, low compliance, high recoil. So getting air out is the problem, getting air in is the problem. So now, when you look at COPD as a general disease where the problem is getting air out, there's actually 3 different disease processes that fall under the umbrella of COPD: emphysema, chronic bronchitis, asthma. We touched on this earlier when we talked about VQ mismatch. But in COPD or emphysema, the first type, here the destruction of the terminal bronchioles and alveolar sacs makes it very compliant, but with very little elasticity. It gets deformed. Blood flow around the alveolar sacs are impaired. It's much more of a Q problem than a V problem because of blood flow. You have impaired gas diffusion as well. The expiratory phase increases as the resistance from these destroyed bronchioles hinders movement, and you get hypercapnic or hypercarbic. There's kind of a cross-section schematic of what that looks like. You can get chronic shortness of breath. If you start getting a lot of sputum production, then maybe they're moving more into the chronic bronchitis phase. But but emphysema is going to be characterized by especially exertional dyspnea. Chronic bronchitis is the one where the tubes then are full of the goo, lots of mucus production. These bronchi are secreting mucus all the time, hypersecreting mucus. Because exhalation is a passive process, it's kind of hard sometimes to get past all this mucus and stuff. And so expiratory phase again is increased. So when you have a COPD patient and they have to be intubated, one of the things you really have to worry about if you're not paying attention on the ventilator is what? Besides peak area pressure, yes. What's one of the things that we don't often manipulate? I to E ratio, right? So what do you think you're going to have to do with a really bad COPD or that you just intubated? Is the I time going to be longer or the E time longer? E time is going to be longer. You need to allow it as much as possible to exhale. What happens if you leave the IE ratio normal? And then what happens? What was he describing when he did that? You're stacking breaths, right? Because you're giving a tidal volume, and then they haven't quite finished exhaling. Then you give them another full tidal volume. They haven't quite finished exhaling yet. You give them another tidal volume. Eventually, barotrauma is a major concern in intubated COPD patients if you don't at least think about that. Watch your peak area pressures and stuff like that. You're going to have to take Andy Law's class, and he's going to teach you how to do all the different modes of ventilation to optimize that. Yeah.
But just real quick, no matter what agency, what ventilator you're using, what two values or what two settings do you adjust to achieve an increased IE ratio? Yes, rate, and what else? I time. Every ventilator that you're going to use, whether it's a Hamilton or Revell, those are the two values that you can adjust to achieve the extended IE rate. So you're going to reduce your rate, and you're going to reduce your I time. Those are the two ways that you will achieve a longer IE ratio. So
Yep.
just know that operation.
And that makes sense, right? You can't have the same rate if your E time is 4 times longer than it normally is. You can't fit that many breaths in. You have to reduce your rate. And then reducing the I time kind of gives you more E time to work with as well. So doesn't the new Hamilton have a do that for you? Kind of, sort of?
ASV mode,
ASV mode does, right? Okay. Have you guys had the Hamilton vent class? Yeah, you all have. Liz, you haven't had that yet?
Parapack Plus.
Cool. So chronic bronchitis looks a lot like asthma, except you have a lot of excess mucus production and coughing. If you look at this emphysema chronic bronchitis case study, here's a smoker, not on HOMO2 yet, but shortness of breath. There's her labs, there's her lab values, there's her end tidal. Kind of, what are you thinking?
She only smokes a half a pack a day, she's lying.
Well, for 36 years.
At least a pack.
No HOMO2 yet. Mm-hmm.
Yeah, hurricanes are trying.
Her age.
Yeah. Do you think she might live around 88%, maybe 88 to 90%?
90 tops.
Yeah, maybe tops. I mean, so you don't necessarily have to be. I mean, definitely look at her clinically, the sum totality of circumstances, how does she look? She's not on home oxygen yet. That might be because she hadn't qualified for it, or it also might be because she hasn't seen a doctor in 10 years. Okay. If she says, well, I keep asking for home oxygen, but they don't say I qualify, does that change how you look at her 88%? How so? Does it make you think maybe this is acute? Or, man, this is chronic? If she says, I never qualified for HOMO2. Yeah, she said, I've been asking for it, but every time I check it, they say I don't qualify. Then I would be more concerned that this is acute, because I'm like, well, if that's the case, then this 88% is probably new. So I would be more worried that maybe this is acute respiratory insufficiency, not chronic. Versus somebody, we're doing a health fair, and they're coming through, they just happen to check, they feel fine, it's 88%. Like, well, you probably live here. When was the last time you saw a doctor? Oh, I don't know, Nixon administration. Okay, great. You need to go see a doctor. So what we can do for these folks is she might be able to get some supplemental oxygen. I would put the caveat in here that if you think it's acute, then maybe you can give her some O2. But if it's chronic, you don't necessarily have to give them anything. I will tell you that when it comes to acute coronary syndrome, for example, this exact patient, maybe they're not calling for shortness of breath, they're calling for chest pain. and you think this has a classic acute coronary. Do you give oxygen or not? Well, guess what? In people with COPD, supplemental O2 can actually worsen their overall mortality and morbidity. And a lot of protocols will say keep their O2 between 88 and 92 if they're having even acute coronary syndrome and they have a history of COPD, because you can actually make them hyperoxic and reduce their overall, increase their mortality. So just kind of think about that. If it is something acute and they're wheezing and you don't think they're normally hypoxic, then sure, a little bit of supplemental O2. Think about a beta-2 agonist, maybe high flow, BPAP. What's the difference between BPAP and BiPAP? Nothing really. BiPAP is a registered trademark of Respironics. So if you say BiPAP, technically you have to put a little R with a circle in the corner. It's a registered trademark. So BPAP it's the same thing. It's just like.
Just saying BPAP just to throw people off.
Right, exactly. They also can maybe benefit from bronchodilators, from Atrovent, and from steroids. What about ipratropium bromide or Atrovent? Why is it that we give that to COPDers? It's more to dry them up, so more like it's anticholinergic effect. It does have some bronchodilating properties, but because there is sometimes some mucus component to it, it just theoretically helps dry that up a little bit. So if you want to give positive pressure, non-invasive like BiPAP or CPAP, why does that help? Wouldn't that seem to make it like if air can't get out, isn't forcing pressure back in making things worse?
By level, so you give them time to be able to blow off that CO2, right?
Not with CPAP.
Okay, but not with CPAP. Well, CPAP or BiPAP, it doesn't matter.
Oh,
It opens up their airway pathway, so it allows air out. Is that why? If you're using CPAP, it opens them up, it can get out.
Yeah.
It's gonna reduce the amount of energy they have to use to breathe, so you reduce their work.
Right. So you would think that pushing more air pressure in would make an obstructive problem where the whole point is getting air out, would make it worse. But if you think about the pathophysiology, the air sacs, a lot of them prematurely, they don't collapse on themselves because there's no elasticity, right? But the terminal area often closes prematurely. This is still open, but that traps the air. You got a lot of air trapping in COPD. Air can't get out. So yes, that little bit of positive pressure stents it open just enough so that when they're exhaling, they exhale more air out. They can get more air out before it collapses on itself. So that's the theory behind that. It does work, especially in COPD patients when they have COPD flare-ups and exacerbations. A lot of the time, just over 2/3 of the time, it's from a related infection. So when I admit COPDers, I'm giving them not only the beta-2, the Atrovent, the steroids, I'm giving them antibiotics as well. We talk about recognizing obstructive disease in the form of shark finning of your capnogram. Can someone explain to me why you lose your plateau and it shark fins like that?
I was gonna say, it just shows that extra time and effort you need to exhale. Like, 'cause you're not fully getting, it's harder to get the air out, so.
Explain, you're on the right track. So someone pick up where he left off and tell me why physiologically the capnogram looks the way it does.
That plateau is the expiratory phase, and you're not expiring much, so you're gonna have a shorter expiratory phase. So you got a long inspiratory phase, but a short expiratory phase.
That is even closer to the truth. Keep going, pick up where Russ left off.
it's taking longer to expiratory because of the thing is taking longer as it's a sharper plateau because
Well, if the x-axis is time and it's taking longer, that means I should have a line that's longer because it's taking more time. But in fact, it's shorter. Okay, someone tell me what does this capnogram measure? Yes, let me ask you this. In a normal capnogram, you wrote this short. In a normal capnogram, why is it that the more you exhale, It gets flat, 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 and then it suddenly drops like that. Well, how come the line doesn't keep going up? In other words, why does it around here, you're still exhaling, and it's still going up, but it's not going up as sharply as there.
You're almost at your max pressure on the way up.
This is not a pressure graph. This is not a pressure graph. Of what? It's carbon dioxide, okay? So the reason why this is so sharp is because now the sensor at the end of the tube or wherever is detecting the CO2 coming out of your lungs, and as you continue to exhale, the CO2 here is not the same as the CO2 here. This is from the top of your alveoli. This is from the very deepest recesses of your alveoli, okay? So you are emptying out your alveoli, and this would keep going up if you could exhale that long, but at some point in time you have to take a breath. So that's when you have to take a breath, and it goes, you inhale, and the sensor suddenly detects 0 CO2, and it drops like a rock, okay? And these people, it looks like this, and then like that, because they're exhaling to the point where they're getting the deep CO2 that's in their alveoli, but they're still exhaling, and it's having trouble getting out, and then they just have to take a breath. They never fully, here we're fully emptying our alveoli, so it's flat. They can never fully empty their alveoli because of all that obstruction.
Do they do that to maintain PEEP, the exhale PEEP?
No, it's not necessarily about quickly, it's just that they have to inhale before they can exhale fully, and that's why they get air trapping. They need oxygen more than they need to exhale. Exactly. Makes sense? So where, and hopefully this kind of helps a little bit, but where does exhalation start on the capnogram? A, B, C, or D, or E? Does exhalation start at B, C, A, B, C, or D? Most people say exhalation starts here at B, right? Because when you exhale, it's detecting, right? Exhalation starts at A. So why is it flat? Dead space. The very first milliseconds of your exhaled air is air that never participated in gas exchange, so it's flat. But then, as soon as the first bits of waste product from the alveoli comes up out of your trachea and past the sensor, it starts to go whoop, and it detects it. Okay, then you empty it out, and then D is where you inhale, but D is also your capnogram. That is your end-tidal CO2 number, okay? Because that's the end of your exhalation. Okay? So this makes a lot more sense if you understand where exhalation starts and like what the capnogram actually means. Then the shark finning makes all kinds of sense. So it's not a pressure wave, and it is somewhat of time because the x-axis is time. But if you realize that the capnogram, the shape of the waveform is measuring CO2, and it's from different parts of the lung, A, dead space, B, primary bronchi, bronchioles, terminal bronchioles, and then the alveoli, then deepest part of the alveoli, and then you inhale again, it makes sense. These poor COPD patients just can't get all the way there because they can't fully exhale. All right. We just briefly mentioned this concept of hypoxic drive. Is that a real thing or a fake thing? Well, so the hypoxic drive in late stage COPD, of course, severe retainers of CO2. There is the theoretical fear that if you give a COPD or oxygen, you'll make them stop breathing. So bottom line up front, that's not really a thing for emergency medicine, much less for EMS. It might be a thing for the ICU intensivist, but for me in the emergency department and for me on the ambulance some days and you on the ambulance, if they need some oxygen, give them some oxygen. Don't worry about depressing their drive. That's not something that happens in the emergency department. It's not something that happens quickly. It's something that might happen in the ICU. Okay, that's the bottom line up front. Okay. So the rest of the story is you get a drop in CO2 from the hemoglobin when you get a lot of oxygen. You pick up extra O2 in the plasma, but in this patient that is normally retaining, now you're throwing off that balance, causing a buildup of CO2, increase in actually worse hypercapnia over time. They're getting oxygen, yes, but at a cost, and a long-term, a potentially fatal cost. But again, that's not going to happen in the ambulance, not going to even happen in the emergency department. Okay. The other thing that happens is VQ mismatch. You should be well versed in that now, but more dead space ventilation, because remember, O2 is and so over administration of O2 may vasodilate some of the pulmonary capillaries, increasing flow to the bad alveoli. So the alveoli that aren't even participating in gas exchange, you're giving more flow to that. So now your Q is more, your V is less, and you're worsening your VQ mismatch. Okay. So that results in hypoxemia, ironically. So when we maintain our O2 about 88 to 92, we're trying not to trick the hemoglobin and throwing off more CO2, and trying not to reverse the compensatory VQ mismatching that has occurred. If you have somebody who's intubated, you also just want to try to avoid an FiO2 of 1. If you can get away with a low FiO2, 0.3, maybe 0.4, that's plenty. That's good enough. Okay. So think about people that live normally with a high CO2. As a result, you might see the bicarb being kind of high, but with a normal pH. And so I would say it's more helpful to look at their pH than anything else if you're trying to decide what to do with their respiratory rate. So if they're acidotic, maybe you can decrease tidal volume and give them a little bit of a more rate, but then you also have to balance, look at their peak area pressures and make sure you're not stacking breaths and all those other things. These are very difficult patients. When you intubate COPDers, man, that's a tightrope, and it's very hard to manage them. The concept of permissive hypercapnia. Is this a normal EKG? Not EKG, ABG. It's not. Would you say that it's compensating or not? Why do you think it's, if anything, it's on the compensated side? What is it that makes you think? Because the pH is, I mean, it's on the low end of normal, but it's normal, it's 7.35, okay? So this is probably chronic, and this is more of a chronic compensated respiratory acidosis. So pH here is the key. When you look at COPDers who live in a respiratory acidosis, then a PCO2 of 80 may not be the worst thing in the world. So when I get these COPD patients in the ER, and I get an ABG, and they're on their BiPAP or whatever because they're acutely decompensated, I'm not so worried as if I would be for a non-COPD patient that came in with a CO2 of 80. The advantage I have is a lot of times I can look at prior ABGs and see, oh yeah, they always live around 75 to 85, so this is actually not way off of their normal, and we can allow them to be a little hypercapnic.
This guy's probably going to look fairly asymptomatic.
Yeah, they may be more shorter breath, and that's why they came in, but they're not obtunded, you know. A normal person with a PCO2 of 80, they'd be at least lethargic, you know, so.
I was going to say, seeing that CO2 without seeing that pH and bicarb and everything, like you just had end-tidal, that would kind of freak me out a little bit.
Yeah, all right, so I realize, I just want to acknowledge, I realize these are very long days and you're getting tons of information in a relatively short amount of time. Your brains are full, I know, but it's not quite full yet because we have a little bit more to go. So what you'll notice is that in the interest of time, just because I don't think it'll be possible to get through everything by 5, what you'll notice is that the asthma section, I have skipped ahead to this slide, which you can find in your notes. Everything else about asthma, it's very straightforward that you can read. I think asthma is one of those things where most people are pretty familiar with asthma, and that's not like it's something that you're unfamiliar to you. So just go ahead and read that. What I have skipped ahead to is some of the more salient clinical points that would be more helpful for you, especially as a critical care paramedic. So let's focus on that for the remaining time that we have. Number 1, when you are intubating patients with COPD, obstructive lung diseases, particularly COPD and asthma. There are some clinical pearls, some clinical nuggets that we want you to think about and apply when you're doing these critical care transports. One of the first things we have alluded to already, which is think about their respiratory rate and their I to E ratios. So someone tell me why we have to manipulate their respiratory rate. Are you going to increase it or decrease it, and why? So that you can give them more time to exhale, right? So one of those things is you can decrease the I to give you more room on the E side. Your respiratory rate is going to be more like the 6 to 10 range to fit that expiratory phase in and let them get rid of more of their air. So that trapped air, if you're doing it right, you're helping to stent those airways open, get more of that air out. Okay. The other strategy, why would your PEEP be a little bit higher than normal?
Help them get the air out.
Yeah. So again, they're intubated, right? But that doesn't mean you can't still give them the same kind of benefit that your CPAP did before you intubated them, in that you're helping to stent those airways open a little bit and get more air out. Remember that a lot of COPD patients do that on a regular basis when they're sitting at home watching TV. How do they give themselves more PEEP? Pursed lip breathing. That's the whole point of pursed lip breathing. They're creating a little bit more back pressure. They don't even know what they're doing. They just know that I notice that when I breathe out that way, I feel better. I can get more air out. I'm not so tight in my chest. They're giving themselves more PEEP. They don't even know that they're doing that. Okay, so yes. Look, that patient's creating PEEP. Yes, I should be. But you're good. I should double check. Sometimes I forget to turn it on. And yes, it is. Okay. The other one. The other strategy when you've got them intubated is, or maybe you're picking them up and you got a brand new ABG fresh off the lab as you're rolling out the door, and you notice their CO2 is 80. Sometimes you can allow for permissive hypercapnia. Why is that? Because that might be their baseline, right? That may be where they live, and usually you can get that report from the facility when you're moving out. Lower than normal FiO2s, that as well. And remember, we talked about the two ways that we can sometimes paradoxically make things worse if we're hyperoxygenating chronic respiratory failure patients. Good. How about the fifth strategy, maximizing beta agonists and steroids? Okay, keep them open, help, especially if it's asthma. You know, sometimes with emphysema, it may help a little bit, but asthma, unlike emphysema, is reversible. That's one of the primary differences of chronic bronchitis and emphysema, which is considered non-reversible. You can mitigate some of the effects, but asthmatics, you can turn around almost completely if they're responsive to beta agonists and other bronchodilators like ipratropium, and you reduce mucus production and you give them some anti-inflammatories. They get some Solumedrol, for example, or prednisone. A lot of times you can get them back to baseline, which is pretty darn near normal for some asthmatics. And then this last one very important strategy is using volume control over pressure control. And why is that? I'm not asking him. When you take his vent class, he talks about this. That means all of you should know the answer to this. He's going to make you take it again.
Using volume, because we don't want to cause trauma.
Barotrauma. Mm-hmm.
The pressure. So filling volume, or title increasing the pressure.
Right.
Doing a low pressure situation.
Mm-hmm. And so, especially here, since we're using the Cadillac of ventilators, new Hamilton T1s, what do you suggest that they do when you've got the COPD or intubated?
We use PRVC, which is the combination of volume and pressure, but we're targeting volume because we want to take it away, Doc?
Yeah, no, I want to know, to be consistent, say the same thing you say in your class.
So they have to get, or ideally you want them to get a reasonable volume, right? And so it's a define and control. We want to define that, because if you say might give the pressure you want, but the volume might be only 200 mils, 300 mils, and it's gonna hold that pressure for the duration of the inspiratory breath, which is probably a fraction of a second because you're really dropping all the things down. So if you say, hey, I want this person to get 500 mils of air, as it's meeting resistance of the upper airways and everything else, it's still trying to force feed the volume in. And if it doesn't get it, the next breath is gonna give a higher pressure to achieve the volume that it needs to get. Does that make sense? And so that way you actually have a defined, measurable minute volume that you're achieving, that you want, as opposed to this guessing game, and it's not necessarily increasing the pressure that it needs to, and they're building carbon. So,
So you're getting a variable time volume for each breath, you're saying?
yes, either way, you're getting a variable time volume, but pressure control is like a complete variable. You have no control, no idea. So at least with volume, you're making your best effort to achieve the proper tidal volume. And then the ventilator with PRVC is going to make adjustments to the pressure so that you do achieve the volume that you want. As opposed to if you only did pressure control, it's a guessing game, and you're always having to watch breath by breath and do it yourself, and then increase the pressure of yourself. And in the meantime, the patient's struggling, like they're hungry for air. So if you lead off with volume control or PRVC, you're at least targeting, you know where you'll make your modifications. If you're only in volume control, then you'll hit a high pressure limit, and you'll only recognize, hey, I only delivered 100 mils of air, right? So then there's also feedback of, hey, well, my ventilator's working and my resistance, and so on and so forth. So volume control is a lot more therapeutic for the patient, and gives you a definitive finish line, as opposed to pressure control. You're just wandering aimlessly in the dark, knowing that you need to go a certain direction.
And we're very lucky we have PRVC. It's an elegant way to really ride that line, and make the patient as comfortable as possible. But man, it sure does take practice, for sure. I think the majority of our intubations here would be put on ASV, but wouldn't you agree? But for these patients, this is why we're talking about it.
Very much so with these patients throw ASV for a loop.
Yeah.
Because ASV targets a minute volume, and it doesn't recognize your patient demographic. It tries to, but it's not as therapeutic as if you did this manually. So it's probably the first few minutes, the patient's actually going to suffer because it's trying to find a reasonable rate and everything to achieve a minute volume of the high end. Within the first 5 minutes before all of your drugs hit, your actual deliver minute volume is remarkably less than what the actual patient minute volume should be because of your resistance and the airway constriction. So if you manage this on the front end, you do the titration almost immediately, so it's immediately therapeutic for the patient. They're not uncomfortable while the ventilator's trying to figure it out.
Yeah. I would suggest if you intubate one of these patients that you don't start with ASV, right? Go to PRVC.
If you're not comfortable with that, you should already have a BC running. Well, I guess in our district, right, if you're intubating a patient, you should already have a BC that's pretty proficient with the ventilator. If you're not, this is where you start. Like this is the patient, because this is the bulk of patient demographics that you get. So this is where you want to refine your proficiency with the ventilator with these patient demographics, and then work your way down to usually ours is my last patient demographic that I try to refine the skills, because it is very skillful for the patient population that we run on with ARDS. Negligible compared to the patients that you run with COPD.
And you want to knock these patients out hard too. You want to sedate the crap out of them to get them down hard, so you can take over everything you need to take over.
Every help possible if you're not proficient, especially on a peer transport, like absolutely. So for a therapist, consult with your senior medic, consult with someone. These patients can be super brittle. Like one wrong setting for 30 seconds, 1 minute, they will crash hard. Because if you don't control this, you will affect hemodynamics remarkably with the intrathoracic pressure. So you can go crazy on pressors, and that's not what they need. They need control of ventilation.
Yeah. In fact, that's a good little nugget, is if you have a primarily respiratory failure patient like this, COPD, and they're newly intubated, or you've intubated, or the hospital has newly intubated them and you're getting them someplace else, you really got to think really hard about hypotension and pressors if their entire history is pointing to a respiratory problem, you got to think, I got to drive this vent better or find better settings or something, and not think that they're needing pressures. It's not like you're picking up a uroseptic patient, his pressure is 80 or 70, right? It's a respiratory failure patient, respiratory insufficiency, progressed, got intubated for what's thought to be a COPD exacerbation. He's right, you affect the hemodynamics very early on, especially with bad vent settings. So this is something that just takes some practice. But think about that. And kind of along those lines, there are some things, whether it's COPD, chronic bronchitis, or asthma, it all kind of in the COPD family. But remember, we said asthma is reversible, the other two are not, but there are still some common themes for both, along with some very different things to think about for both. So another helpful thing would be, what are the things that are common to all three? Well, tidal volume management and respiratory rate. These are all three. You kind of have to think about, do I start high or do I start low? If anything, you're going to start low and titrate as needed based on starting at between 6 and 10, but you're not going to start at 20. Okay, so you can increase as the patient does better, for sure, just so that you take the equipment out of the equation. Make sure that you are able to effectively oxygenate and ventilate them from the mechanical standpoint, and try to use as big a tube as possible. If you normally intubate with a 7.5, try an 8. If you think you can get an 8 in, try an 8.5 if you're the one doing the initial intubation. Remember, what's the minimum size that you can bronch through? 7. A 7. So 7 is pretty small for this kind of a patient anyway. So, I mean, I usually start with a 7.5 because it's kind of a nice in-between male-female. But in this particular case, you might want to try to go up half a size and just see if you can do it. But understand that, as usual, when you're intubating, if you're the one doing the intubating, have your backups ready, backup tubes ready, et cetera, but at a minimum of 7, because that's the smallest you can bronch through. And these people will most likely need a bronch. But giving them as big of a lumen as possible to begin with is going to be really helpful. Plus, they're more than likely going to need a bronch. Remember, we talked about the increased I-to-E ratio, allowing for that longer exhalation time to get air out, and there's a couple of elegant ways you can kind of manipulate respiratory rate and I time to get that end goal of allowing for more exhalation time. However, there are some key differences between the reversible and irreversible to at least consider if they're intubated on the vent. So with COPD, we know that it is most likely they didn't develop COPD overnight, and it's a chronic condition, a chronic form of respiratory insufficiency. So think about starting your FiO2 a little bit lower. You don't have to start at 100%. Whereas in asthma, if an asthmatic is being intubated, that's what we call a fatality-prone asthmatic. And oxygenation is going to be probably one of your biggest problems. So it's okay to start a little bit higher at 100%, titrate down, rather than starting low, titrating up like you would in COPD. The other thing is, because COPD is pretty chronic and that about 70% plus of COPD exacerbations have underlying infection as one of the triggers, asthma is not always that way. It is not customary to start antibiotics on asthmatics that we intubate like it is for COPDers. We do give antibiotics pretty routinely, in fact always, for COPDers who get actually not only intubated but who get admitted. If we're admitting them, I just start antibiotics on too. Also, with COPD, we talked about stenting some of those alveoli open, giving them PEEP. In asthma, it's a reversible bronchoconstriction that really, I think it's less than 5, if not 0. That's what ZEEP is supposed to mean, 0 PEEP, ZEEP. The next two are pretty related as far as when to use paralytics. So in COPD and asthma, both can be pretty risky, asthmatics especially so. Why is that? If you're not very intentional about managing that vent correctly, I'll give you a hint, especially as it relates to respiratory rate. What's the risky part there? They're both risky, asthma even more. Barotrauma is always very risky, yes. There's something even more deadly. So if you're not very intentional about the settings on your vent, they're both, it's both risk. Both COPD and asthma, it's risky to intubate them. If they're getting that bad, for one thing, there's mortality associated with it. But if you're not very careful with your settings and you get lazy, it can kill asthmatics in particular. And what is that? What is it that I'm talking about? I'll give you a clue. What setting am I talking about? Besides that, besides barotrauma, what about rate? That's okay.
The rate and the IE, so if you can decrease your rate, that'll help you increase your expiratory, right? I think.
Yeah, we talked about, that's a common theme for both, is just being cognizant of your IDE ratio, at least early on. But remember, we said asthma is reversible, so we're hoping that with very intensive interventions, therapy, even epinephrine for really bad asthmatics, I'll give them epi, sub-Q epi. We used to do it all the time. Yeah.
That's all we had.
I don't think we do that enough for asthmatics.
I mean, it's a short half-life.
Yeah.
Fixed and done.
But hopefully it gets to be reversible. But which population is more accustomed or more used to a high PCO2? The COPDer. They're probably a little more baseline acidotic or low end of normal, baseline 735, 733 all the time, right? But is the asthmatic always hypercarbic and acidotic? No. So one of the worst things you can do for an asthmatic is say, oh, they have really bad asthma and they're breathing, 40 times a minute and wheezing horribly and hardly moving any air. I'm going to take their airway. And you intubate them and you set them on a rate of 6 or 10.
So you fix the problem and then.
So you've taken their airway, but what have you done to their acid-base status? I mean, basically, they're no longer able, from a respiratory standpoint either, to get rid, they're tachypnic for a reason. So if you're not really careful about that and you leave them at a rate of 6 when they were breathing 40, you remove the compensatory ability. So that's another thing to be really, really careful about, is think about the underlying pathophysiology of the patient. Think about everything that's going on. Yes, monitor their pressures. Yes, monitor their peak area pressures. Yes, monitor their IE ratio and all these things. But you also want to worry about unchecked acidosis. Okay, so that's something that you really want to be careful about. If you give them a paralytic to a COPDer, most of us are pretty good about monitoring that. But with an asthmatic, if you don't allow them to overbreathe the vent, and therefore, even if you set the rate at 6 and they're not able to start breathing over that vent with a paralytic, you've sealed their doom, right? Suddenly they start crashing and then their ABG is 6.5 and you're like, oh my gosh, I totally forgot. So that's not good either.
There's a study that says it only takes about a minute or two in a low pH asthmatic patient. A minute or two is all you have.
Yep.
So you crash their pH to where mortality increases by 80% or something.
Yes.
It's mind-boggling.
They crash fast. So that's why you really, especially in the asthmatic, they're not accustomed to acidosis. They're not chronically acidotic. They're compensating pretty well. Now, I cannot remember the last time I intubated an asthmatic. I've intubated COPDers, but asthmatics, I mean, the most I'll do is give them BiPAP, very sub-Q epi, mag, drips, solumedrol, continuous, 40 milligrams of albuterol on a continuous inline neb. But I am loath to intubate them because literally, if you do it wrong and you don't get the settings right and you hypoventilate them suddenly from 40 to even 10, by the time you're done taping the tube in place and getting a chest x-ray, they're crashing. And it's no bueno. Yes. It is a nightmare. So if they're at least breathing and halfway talking to me, no matter how bad they look, man, I give them a ride on the BiPAP at least and hit them with everything. My long neb, my mag drip, my epi, my prednisone or solumedrol, and just let them be. Question?
Yes, I feel like the only time patient, because for an ET tube, it's more so to protect that airway, not necessarily an airway. So you
Yeah.
want the definitive care for them.
I think if they're to the point where they're starting to be obtunded and like now they're slowing down their own, now they themselves are not even hyperventilating anymore, and they're like, that's the only time. But even then, we would make sure that we are hyperventilating. Like we count their respiratory rate, we match that respiratory rate, and we watch them like a hawk, and we just do our best to try and match their compensation. But yeah, they're super, super challenging. So I would hesitate greatly before I intubate an asthmatic. So just remember that. And finally, auto PEEP, that's the other thing. Auto PEEP is a concern for both, but for asthmatics also that can be deadly. So make sure that you're not taking away their compensation and that you think really long and intensely before taking that airway and have a really healthy respect for it. The other thing, ARDS, and Chief, you already went over this?
No, not really.
Oh, not really? Okay, good. Quick overview of ARDS. ARDS is, depending on when the literature was written, is acute respiratory distress syndrome or adult respiratory distress syndrome. Either way, it spells ARDS, and it's bad. So this ARDS is basically, if you look at a normal versus an impaired alveolus at the acute phase, ARDS is something, it's an umbrella term that really refers to where the pulmonary vascular permeability is changed such that you have a change in lung structure and function. It really affects that alveolar capillary membrane interface. What do you notice about the normal versus the ARDS alveoli cross-section there? About that AC. Look how much thicker it is. So remember we talked about diffusion and how permeability and distance to travel is directly proportional to its ability to diffuse. Well, the thicker you make that membrane and the thicker you make that, stiffer you make that membrane, the more difficult it is to allow diffusion of oxygen and carbon dioxide in pulmonary exchange. So now you got all this fluid buildup, all this inflammation in the interstitial space between the alveoli and the capillary, and that will eventually lead to alveolar collapse and destruction. And just look how it's starting to fill up now with fluids and such like that. ARDS is among the worst conditions that you're going to have to face and one of the most challenging because now it is kind of both a V problem, which it really is. I guess less Q because the blood is still flowing around it, but it's just not able to diffuse as well, and you have a lot more destruction of the AC membrane itself. But it is also a very challenging condition to deal with. What do you think all that fluid in the alveoli does besides obviously fill it with gunk and making it impossible to take air? It also damages the surfactant. It disrupts the surfactant layer in the alveoli. Surface tension, therefore, is decreased, and it tends to collapse a lot more, so a lot more easy to consolidate and completely obliterate that alveoli. So ARDS starts with neutrophil activation, which further activates other inflammatory cytokines. Your surfactant gets disrupted. Now your permeability of the AC membrane increases, which allows more fluid to seep in. And you can kind of see all those things happening up in here. Very protein-rich edema fluid is now filling it. The activated neutrophils are releasing all these leukotrienes and proteases and cytokines and interleukins, all pro-inflammatories, and more fluid just keeps piling in. So the Berlin criteria is something that we mentioned briefly in our case study, where that scoring kind of helps you, for lack of a better term, it classifies it into mild, moderate, or severe ARDS. And so the Berlin criteria usually is applied to patients who have relatively acute onset of respiratory failure. You get white out of your lungs. Have you ever seen a chest x-ray with ARDS? It's ugly. It's all patchy white all over the place. I think we have a picture of it actually coming up. Here, your PF ratio is less than 300. So it's a pretty good 90% sensitive test for detecting it. This is non-cardiogenic pulmonary edema. This is very important to know as well. Cardiogenic pulmonary edema means what? Versus the heart is the problem. The heart is failed, therefore causing back pressure in the pulmonary circuit, causing edema buildup. But this is non-cardiogenic. The heart's fine. This is the lung that's the problem. And the thing that's going to help overcome some of that surfactant disruption and fluid buildup is some positive pressure. So PEEP is going to be needed, in fact, usually more than 5. A PEEP of 10, maybe even 15 for severe ARDS to try and overcome that physical barrier of the fluid, the AC membrane disruption, all the inflammatory gunk building up there. So ARDS can be caused by a bunch of things: pneumonia, alcoholism, often from aspiration, chest wall trauma from hypoventilation, inhalation and smoke inhalation. Sepsis and pancreatitis are two big ones that can trigger ARDS. TRALI, what's TRALI stand for? T-R-A-L-I. Transfusion-related acute lung injury. So massive blood transfusions can lead to ARDS. COVID ARDS we saw a lot. And drowning. I haven't had a chance to fix that yet, but there's no such thing as near drowning. There's no such thing as secondary drowning. There's no such thing as it's drowning. Drowning simply means respiratory dysfunction at an air-water interface. So there's 3 outcomes for drowning: drowning with no morbidity, drowning with morbidity, drowning with mortality. So drowning doesn't mean dead. You can drown and live. All right, but so I think near drowning used to be a term, but it's been replaced about 5-6 years ago. So know these causes. They're pretty common causes, but especially sepsis and pancreatitis. Oh, here's the picture. Nice. So really, they both have bilateral infiltrates, but you'll notice that on the non-cardiogenic and the ARDS, it's much more diffuse and patchy. You'll also notice that it's pretty homogeneously distributed versus cardiogenic tends to be more kind of in the lower half. There's also no curly B lines in non-cardiogenic shock. Curly Bs, it's really hard to see up in here, but they're little lines that come across from the periphery of the lung that extend into the parenchyma, and pretty characteristic of fluid buildup in cardiogenic shock versus non-cardiogenic shock. Notice in the ARDS, it's much more diffuse and top to bottom. It has a very characteristic cotton candy-like look all over the place. Yeah.
Why does pancreatitis cause ours?
Why does because pancreatitis is a itis being inflammation. It's kind of inflammatory, and pancreatitis, when it causes ARDS, is typically the trigger also of SIRS, systemic inflammatory response syndrome. So when it triggers SIRS, and if the pancreatitis is bad enough that it does that, you'll more than likely get ARDS as well.
On this slide, guys, put or question. Every FBC I ever took had a question where you had to identify what ARDS looks like on chest x-ray. It's a guarantee.
Big star by this chest x-ray.
And the big one is the opacities, the ground glass appearance. They're called opacities. Make sure you know that. The opacity is referring to the ground glass appearance of the
Secondary drowning, or something that they refer
It's
to.
just
Is that
identifying
inflammation after
opacities,
somebody
so
does
I
take
think
in
Yes.
some water? And then that's the one that can be a problem, like
Well,
whatever.
if they get ARDS, that's drowning with fatality due to ARDS, but it's not secondary drowning or dry
Secondary
drowning.
is a thing, and it happens, like,
That's also called dry drowning
yeah.
because they're at home after they fell in the pool, and then a few hours later they drown when they're in their living room, and that's just ARDS.
Okay, so that is,
There is no dry drowning, there's no secondary drowning.
She said children's for like 2 days just for that.
Yeah.
She went in a respiratory.
good. That would be drowning with morbidity.
Yeah.
Yeah.
Middle ground.
You know, technically, if you jump in the pool and you come up and cough and sputter, bleh, it's drowning, but no morbidity. You're fine. You cough it up and nothing happens. You're fine. Okay, so board question. Make sure you know that. Now, of course, the question weighing on your minds is, well, how do we treat it? And remember that ARDS, this is a respiratory failure, and it is a hypoxemic respiratory failure. So really, you want to make sure that you maximize oxygenation as much as you can. ARDS involves changes in elasticity, compliance, resistance, especially in like COPD. So how would you define, or how would you talk about elasticity versus compliance versus resistance? Compliance, resistance, elasticity, or recoil. Compliance and elasticity, okay? So if you had to explain it to a paramedic student, I don't know what that means and this means. So compliance, what does that mean? That means they breathe?
Ease at which the lungs and, right,
Does everyone agree with that?
nice and stretchy, but not too stretchy.
Not too stretchy. So it's good compliance versus bad compliance. What do we mean by that?
Bad compliance, they go back too fast, they snap.
Well, so what's elasticity?
Go back to the shape.
So it snaps back?
Ability to return back to its.
If they have good compliance, they have good expansion.
Okay,
So they're not able to do expansion with the arts because of all that.
okay.
Remember the rubber band analogy we talked about, right?
What is the rubber band analogy he talked about last week? I wasn't here last week, so what did you say it was?
So compliance is pulling back the rubber band, that's filling the lungs. Elasticity is when you let the rubber band go, it's going to return back to its original shape. Unless you pull that rubber band back 1,000 trillion times, then it's going to be a lot more floppy.
Yes.
So elastance is the way the rubber band or the lungs return back to its original shape after the air has left it.
That makes sense?
Yeah.
So if you had to give a definition of compliance, describing compliance in words, you can say compliance is the ability to deliver a given volume of air at a given pressure. So if I were to take just a little bit of pressure, like, that's it. You know, not a whole lot of pressure. Would it be easier to blow up one of those plastic grocery bags from Schnucks or a birthday balloon with the grocery bag, right? So the grocery bag has much more compliance because for the same amount of pressure, I can fill a whole grocery bag and probably not even get a budge from the balloon, which is not very compliant. Which has more elasticity? The balloon does. It has much more recoil, right? Like that rubber band. You stretch your rubber band, you let go, boing, you know, that is very elastic, but you do the same thing to the paper bag, it stays in that shape, very low elasticity. Okay, so which has more compliance? Emphysema or pulmonary fibrosis? Emphysema, very compliant. Which has more elasticity or, recoil? The pulmonary fibrosis does. Okay, but pulmonary fibrosis has very low compliance, right? It's very hard to get any air in there because it's thick-walled, not very much. It takes a lot of pressure to get air to fill the same volume as it would with normal lung tissue or emphysematous lung tissue with high compliance or good compliance. Make sense?
Yes.
Grocery bag, rubber band, or a balloon. Okay? So everything is about, in ARDS, finding that balance between enough tidal volume and getting air in, as well as PEEP, keeping it stented open because the surfactant is disrupted and it's full of crap and fluid and cellular debris. Okay? So you want to find a PEEP that will prevent alveolar collapse, and you want to prevent barotrauma on the other end when you're delivering a tidal volume. So it's going to be this push-pull relationship as the disease progresses. Hopefully, as the disease is getting better, overall compliance will improve and elasticity will improve at the same time. And as you get rid of all that edema that non-cardiogenic pulmonary edema, oxygenation will improve, ventilation will improve, but it can take days or weeks sometimes for certain ARDS patients.
So is this one again, if we had an event that PRVC would be?
This might be a good one to try as well, because the entire lung is affected. But yeah, it's finding a volume and PEEP that will work the best. I don't know that, I wouldn't say that it's entirely as tenuous as an asthmatic is, but they can still be pretty tenuous. ARDS is one of those also nightmare scenarios because the entire lung is involved. And there's a very high mortality associated with it anyway. Think about the underlying causes of the ARDS, like pancreatitis by itself, without ARDS even has a mortality associated. Sepsis, very high mortality associated, even without ARDS. So you put organ failure on top of sepsis, your mortality goes up even higher, another 10 or 20%. So the trick is finding that balance between peak pressures, tidal volume, and PEEP to maximize oxygenation and ventilation. It's not like pneumonia where it's just the right middle lobe that has pneumonia and everything else is fine. This is the whole lung, as you saw on that x-ray, the whole lung. One of the things that you can do is starting with high O2, high PEEP as well to help stent it open as much as you can. In COVID, early COVID, they found that hyperoxia can be bad for whatever reason, COVID being the weird duck that it is. So make sure that, thankfully this is not as common as it was 4 years ago, but if you are transporting a COVID patient on the vent settings that seem to be working, just keep those. I haven't seen any prone positioning of COVID patients in a long time. Did anyone here transport those patients? You did? Prone? Yeah. That was really challenging, for sure. Did they also tell you to keep the O2, SpO2 a little bit lower at that time or not? Do you remember?
No, I mean, not at that time. Those are just some studies I found on it that talked about the post-COVID. They were finding out that high O2 levels were causing.
Yeah. With ARDS, the lung protective strategies are key. A lot of the main lung protective strategy literature actually came out of WashU, a guy by the name of Brian Fuller. And he did a ton of studies out of the ICU and the emergency department combined, and was one of the first to really champion this low 4 to 6 cc per kilo of ideal body weight. And it really has made a big difference in improving mortality rates. But what you're trying to do is prevent that barotrauma we talked about, and overdistension, aiming for as low of a P-plat as possible. If it is high, then decreasing the tidal volume is one strategy to help reduce that. What you can do if they are pretty hypercapnic is increase their tidal volume and then respiratory rate. Some permissive hypercapnia can be acceptable. I guess it'd be good to also know what their past medical history is, whether they had any kind of obstructive lung disease in the past, how acutely they were ill. But really, lung protective strategies are key. And I did not get this table. What was the take home with this, Chief?
Well, you can choose to do a higher PEEP versus a lower FiO2 versus a lower PEEP and a higher FiO2. And the studies have led out to know that the higher the PEEP, the lower FiO2 had greater benefit for the patient than the other way of doing it. So I saw patients with a PEEP of 20, PEEP of 18, 16 is not, just to maintain a saturation of 94 degrees. Horribly hypoxemic and hypoxic.
That's pretty high. Wow. All right. Oh, here's a example of a prone patient. Why do, and especially in COVID, why did we prone out patients? What does that do? What's the purpose of it? Yeah, it's recruiting more usable lung tissue, using gravity to your advantage. The fact that you can open more alveoli that have been closed by gravity, improve the VQ mismatch. And if they're already prone, just ask how long they've been in this position and double check, absolutely after every move, double check the ET tube. This was something where whenever a patient was transferred into Barnes in the prone position like this, especially during COVID, this was like a 8 or 10 person move from the ambulance, at least early on, stretcher to the ICU bed because the big fear, of course, was losing the tube. And it's really weird to move somebody who's prone. So people aren't used to it. You don't do it every day. It takes a lot of people. One person's only job is tube management during the move, and it was really kind of nerve-wracking.
During COVID, critical care providers here at SCCAD would never transport a patient on prone. Now, I did. I felt comfortable with it, but some did not, simply because the tube is, we're not used to that. We're not used to be able to see the tube and control it, and so they would flip them back over their back and transport them. So, but it's a good idea to keep them if you find them prone.
Mm-hmm.
But they're only supposed to be there for what, up to 4 hours or something like that, the studies bear out. It's not like an all-day thing. They flip them back and
No,
forth,
they do flip
and
them back and forth. But, well, because they're kind of rotating the lung and recruiting different parts of the lung, yeah. I think it's like half a day or something. Because every time you move them, it's really risky. So whenever the move was done, again, you get an army of people. There's one person's job is just the tube, and everyone else was flipping the patient. But it's very nerve-wracking to see. Another one was opposite of COPD. You're giving them more eye time, and they definitely have to have some neuromuscular blockades like paralytics. So pulmonary vasodilators was another thing that was used, as well as things like prostaglandins and nitric oxide, which we're actually going to talk about here shortly. Patients also got the usual things like anti-inflammatories, steroids, beta-2 agonists. The nitric oxide, which we'll talk about shortly, promotes bronchodilation and pulmonary capillary dilation. And then there was ECMO therapy. So why did they do VV ECMO instead of VA ECMO for these ARDS patients? Yeah, because the heart is okay, right? You only need VA if the heart is also failing. If the heart's fine, it's only the lungs are the problem, then you only need VV ECMO, so that's why. All right, so when we talk about compliance and resistance, emphysema and asthma, what are some of the differences and similarities, I guess?
kind of covered that already, I think, Tom.
Did we?
Yeah, we
Okay.
covered all that already.
All right, we'll skip then. I don't think we talked about this yet. Pleural effusion. Pleural effusions are a collection of fluid between the two layers of the pleura. Now, this can be kind of confusing because when people think about there's fluid in the lungs and they see the chest x-ray, if you're not thinking about it intentionally, you can assume that the fluid is literally in the lungs, but it really is in this space. So you see this, the pleura is this like saran wrap that is around, that covers the entire surface of the lungs. But it's actually two-layered. If you look at on a chest x-ray, it's super thin, so it's hard to see. But you shouldn't be able to see that middle layer because it's usually just a very thin lubricant in between the two layers. But the one layer of saran wrap that's touching the lung itself, that's the visceral pleura because it's around the viscera itself. And then as it wraps back around on itself and comes back into the inside of the thoracic cavity, that's the parietal pleura. And in between is this potential space. Normally you can't see it, you can't detect it, you can't get a needle between it because it's a potential space with just a little bit of lubrication in between. But when it fills with fluid in between there, now that potential space is being spread apart. Now you might be able to see it on a chest x-ray. Now you might even be able to stick a needle in between those two layers and suck that pleural fluid out. That's a medical procedure called what? Thoracentesis. So thorax centesis, removal of fluid from the thorax. So when you're looking at the effusion, that's actually where it is. It's not per se in the lung, but it's in that layer between the visceral and parietal pleura. It can be caused by a number of things. CHF can do it just because it's extra fluid seeping through. It can be a pneumonia, an infection as an inflammatory response. It can be from liver, just like ascites fluid builds up. You can also get fluid buildup in the lung. It can be a malignant pleural effusion. In fact, sometimes patients are diagnosed with cancer for the first time because they go to the ER, they're short of breath, they get this picture, there's pleural effusion, long-time smoker, there's a cancer behind there that they've been ignoring for a long time or symptoms, and then finally they have a malignant pleural effusion. So whenever you draw fluid off in a thoracentesis, you always send it to the lab for analysis, including cytology. So they'll spin it down, they'll look for cells, and if they see malignant cells in it, that's a malignant effusion. That means you got to find the cancer wherever that is. It can cause shortness of breath and a cough, pleuritic pain, because it can cause pleurisy and inflammation of the pleura because if it's irritating. Decreased breath sounds, dullness to percussion, decreased chest wall movement on the other side. And here is a good, pretty nice, obvious x-ray of a left-sided pleural effusion. So you can try to treat the underlying cause, whatever it is, but that's the kind where it's big enough that you could probably get a needle in there from a thoracentesis and drain it out. Besides infection, what's the most dreaded complication of a thoracentesis? Causing a pneumo. Okay? As long as you're staying in between those two, you should be fine, but if you happen to violate the visceral pleural as well, and now air is getting in there, then you cause a pneumo. So. But that's okay. Sometimes they're going to need a chest tube anyway because there's so much fluid and it keeps reoccurring. I remember a patient years ago when I was still a resident who had lung cancer, and she was in denial, and she came to the ER every 3 or 4 days to get a giant effusion drained. She had some kind of psychiatric problem where she would only come to the ER. And we tried to tell her, ma'am, I mean, you're here every 3 days. You need to get a chest tube put in and maybe a pigtail drain so it drains it all the time. Wouldn't you like that? Nope, I'm coming here. She was terrified of the hospital, but she trusted us for some reason. And we tried to get her committed, but psychiatry is like, there's nothing wrong with it. She's got full capacity to make the decision. She's just making a bad decision, but she's not insane. She's not. She has decision-making capacity. That's not against the law. So she came to the ER every 3 days to get this drained for like 2 years, until she died. Yeah, but she was famous because, you know, residents have to get so many thoracentesis to graduate. And she graduated at least the entire second-year class. So yeah. It's like, you know what? Maybe we should pay her instead of her coming to here. We charge her. So anyway, that's a really good sized pleural effusion, and you just have to remember and know what kind of effusion it is. Any question on pleural effusions? All right. We're going to finish up with a touch base on these 3 respiratory emergency-related medications. Nitric oxide is an inhaled blend of nitric oxide promotes vasodilation by dilating vascular smooth muscle and increasing pulmonary capillary perfusion. You can use nitric oxide in acute right heart failure, refractory hypoxemia, pulmonary hypertension, ARDS even. When used in a ventilator circuit, you can't use it if there's a lot of water vapor in there because I think it'll just solubilize, right? Yeah, that's why. Once they're on nitric oxide, you can't just stop it all of a sudden. It has to be titrated. Otherwise, it can cause pretty irreversible hypoxemia. Because it is a nitrous donor, prolonged use can also contribute to development of methemoglobinemia. So the dose, the inhalation dose is 5 to 20 parts per million, and it happens pretty quickly as well. Have you ever transported someone on nitric? I can't remember the last time I saw one either, but it is out there. The other one is Heliox. This is a fun one. This is the blend of helium and oxygen. So the main purpose of Heliox is to improve the delivery of oxygen. And why is that? Because helium is a very light gas, right? Lighter than air. That's why it works in balloons to go up. But Heliox promotes laminar flow. It makes it less turbulent. And by promoting laminar flow, you deliver more gas, more oxygen, kind of like a carrier, into more alveoli. And so some patients who just need a little bit less viscosity to improve oxygenation To get past areas of resistance, for example, you can use Heliox.
Get this, because I have local who are just.
Oh, yeah? Okay. I don't think you can buy Heliox, but no known contraindications, but the fun side effect is you sound like Alvin the Chipmunk. Okay. So Heliox, less viscosity, promotes, I guess the take-home message for Heliox is it promotes laminar flow and therefore promotes the more efficient delivery of oxygen deeper into the lungs. Epoprostenol is better known by the trade name Flolan. Flolan is also inhaled, about 50 nanograms per kilo per minute. Onset is very fast, also selective vasodilation of alveoli, capable of VQ masking, basically reducing the shunt. And as it makes its way down to the alveoli, which are still functional, it dilates the vessels associated with that alveolar sac and basically improves that pulmonary flow especially. So it can be given IV, but the ones that I've seen are actually in the circuit on a vent, inhaled. One of the really annoying side effects of Flolan is that it can be kind of sticky and it can plug up your vent circuit. So you just have to be aware of that. Again, it is considered a prostaglandin. Epoprostenol. There are some side effects of flushing hypotension from systemic vasodilation. A pretty short half-life when you stop it, but it's often used for pulmonary hypertension, ARDS patients where they're just having a hard time oxygenating them. So just remember that its mechanism is really decreasing the shunt, improving the VQ ratio by improving pulmonary capillary perfusion.